today for the scientific program. To begin our opening session, it's an honor to introduce Dr. Mat'ab Al-Ataibi, consultant endocrinologist and the program director of the Diabetes Fellowship at King Saud University Medical City and the Saudi Commission for Health Specialists. Dr. Mat'ab is a leading contributor to the national efforts at diabetes prevention and chronic disease management, and one of the authors of the 2025 Public Health Authority Guidelines for Diabetes Mellitus. Please join me in welcoming Dr. Mat'ab.
Assalamu alaikum. Good morning, everybody. It's my honor to welcome all of you to First Diabetes Conference. And thank you for coming to this meeting. Your attendance confirms that you are caring to addressing epidemic our country facing, diabetes. And the beauty of this meeting that all experts nationally and internationally, many of them attending this conference, policymaker, stakeholder, different society with us, public health authority, insurance authority, and private hospital rules, and also expert in the insurance with us. All those people are coming, and you, attendees, and society for takamul with us. So all teams working together to address diabetes in this meeting. Diabetes, not a disease that managed in the clinic alone at all. We need to address diabetes. We need comprehensive care. We need innovations, and we need unified national strategy. This meeting is just the first. It marks beginning of work together, comprehensive care for diabetes care for our nation. Thank you, and I'm sure this is the first meeting, but will not be the last, and many works will come from this meeting. Thank you, and welcome.
Thank you, Dr. Mat'ab, for this introduction. And to complete our opening session, please join me in welcoming Dr. Ali Shamrani, Chairman of the Board at the Takamul Health Association. Dr. Shamrani is an accomplished dentist specialized in oral and maxillofacial surgery and a national leader known for his dedication and advancing healthcare and promoting medical education across the kingdom. Please join me in welcoming Dr. Ali Shamrani.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. دقمر أفرد بديل. حتكلم باللغة العربية إن شاء الله بما أنها لغة المملكة العربية السعودية الأم. الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه أجمعين. أصحاب المعالي، أصحاب السعادة، حضورنا الكريم، يسرني أن أرحب بكم أجمل ترحيب في انطلاق أعمال المؤتمر الأول للسكري في المملكة العربية السعودية، والذي تنظمه جمعية تكامل الصحية تحت شعار تحولات في رعاية السكري من الإرشاد إلى الأثر الواقعي. في هذا المقام يشرفنا أن نرفع أسمى آيات التهاني والشكر والتقدير والامتنان إلى مقام سيدي خادم الحرمين الشريفين الملك سلمان بن عبد العزيز حفظه الله، وإلى ولي عهده الأمين صاحب سمو الملك الأمير محمد بن سلمان حفظهم الله جميعا، على ما يولونه من دعم كبير واهتمام بالغ بقطاع الصحة وتسخير كافة الإمكانات والموارد لتعزيز جودة الخدمات الصحية ودعم البرامج الوطنية الهادفة إلى الوقاية والعلاج والارتقاء بصحة الإنسان وتحقيق مستهدف رؤية السعودية 2030 في بناء مجتمع حيوي وصحي ينعم أفراده بأعلى مستويات الرعاية. أن تنظيم هذا المؤتمر يعد محطة مهمة في سيرة تطوير الرعاية الصحية في وطننا العالمي، ويمثل خطوة رائدة نحو تعزيز الوعي والبحث العلمي وبناء نموذج وطني متقدم للتعامل مع مرضى السكري أن هذا المرض هو أحد أكثر الأمراض انتشاراً وتأثيراً على جودة الحياة والصحة العامة، ويأتي انعقاد المؤتمر تزامناً مع الجهود الوطنية المتكاملة لتحقيق مستهدفات رؤية المملكة 2030 في تعزيز الوقاية والعناية الصحية والحد من الأمراض المزمنة ورفع مستويات جودة الحياة. أصحاب المعالي والسعادة، ضيوفنا الكرام، كما تعلمون يعد مرض السكري أحد أبرز التحديات الصحية عالمياً ومحلياً، حيث تؤكد التقارير الطبية أن نسب الإصابة في تزايد مستمر، وأن المرض يترك آثاراً صحية واجتماعية واقتصادية كبيرة، مما يجعل مواجهة مسؤولية مشتركة تتطلب تكامل الجهود العلمية والطبية والتوعوية. وفي المملكة العربية السعودية يمثل السكري واحدة من أكثر الأمراض المزمنة انتشاراً، مما يستدعي تطوير برامج وطنية شاملة تعالج المرض من جذوره عبر الوقاية المبكرة والتشخيص الدقيق والعلاج المتقدم، وتمكين المرضى ودعمهم في إدارة حالتهم الصحية لضمان حياة أفضل ومستقبل أكثر صحة واستقرارا. أن انعقاد هذا المؤتمر الأول للسكري بمشاركة نخبة من المتخصصين والخبراء وصناع القرار يمثل فرصة علمية ووطنية مهمة لاستعراض أفضل التجارب والممارسات العلمية ومناقشة التحولات الحديثة في نماذج الرعاية وبحث آليات الانتقال من الإرشادات المكتوبة إلى أثر واقعي ملموس يحدث فرقاً في حياة المرضى والمجتمع. ونأمل أن يثمر هذا المؤتمر عن توصيات رائدة ومبادرات نوعية وشراكات فاعلة تسهم في بناء مستقبل صحي أفضل وتحقيق إنجازات وطنية في مكافحة هذا المرض والحد من مضاعفاته. ولا يفوتني في هذا المقام إلا أن أتقدم بخالص الشكر والتقدير للجهات الصحية المشاركة والداعمة لهذا المؤتمر، في مقدمتها وزارة الصحة وهيئة الصحة العامة والقطاع والصحة الافتراضية والجامعات والمراكز البحثية والقطاع الصحي الخاص وقطاع غير الربحي ومنظمة الصحة العالمية على جهودهم وتعاونهم المستمر في خدمة صحة الإنسان وتعزيز الوعي الصحي. كما أود أن أشيد بدور الذين عملوا خلف الكواليس من اللجان العلمية والتنظيمية والمتطوعين والمتخصصين والإعلاميين الذين بذلوا جهدا كبيرا ليخرج هذا المؤتمر بشكل لائق له أثره ونراه اليوم، فجزاهم الله خير الجزاء. ضيوفنا الكرام، من جمعية تكامل الصحية تؤمن بأن صحة الإنسان هي حجر الأساس في التنمية الوطنية الشاملة، ولذلك نسعى بإذن الله إلى استمرار تنظيم هذا المؤتمر سنويا وإطلاق مبادرات وبرامج بحثية وتطويرية وتوعوية تستهدف الوقاية من أمراض السكري ودعم المرضى وأسرهم وتعزيز الشراكات بين القطاعات والمساهمة في بناء مجتمع صحي واعٍ قادر على مجابهة هذا المرض والحد من آثاره. أسأل الله العلي القدير أن يكتب لهذا المؤتمر التوفيق والنجاح، وأن يجعل نتائجه وبرامجه خيراً ونفعاً لوطننا الغالي، وأن يديم على المملكة العربية السعودية أمنها واستقرارها ورفعتها وازدهارها تحت قيادة خادم الحرمين الشريفين ولي عهد الأمين. والسلام عليكم ورحمة الله وبركاته. شكراً لكم.
Thank you, Dr. Ali, for this introduction. And now, as we continue to our opening session, it's my pleasure to welcome Dr. Ayman Sahibani. Dr. Ayman is the Director of Non-Communicable Diseases and leading preventive medicine consultant. Dr. Sahibani has played a key role across major national health institutions. Please join me in welcoming Dr. Ayman Sahibani.
Assalamu alaikum. Your Excellencies, distinguished leader, esteemed colleagues, ladies and gentlemen, it's a deep honor to be with you today. We gathered here with the unified purpose to strengthen efforts to prevent diabetes and enhance the quality of care for those living with it. Non-communicable diseases, particularly diabetes, remain a most pressing public health challenge globally, with more than 70% of deaths related to NCDs. More than 5 million individuals living with diabetes, around the world. And in the MENA region, it's more than 70 million people living with diabetes. This number is projected to double within the next 20 years. The Kingdom of Saudi Arabia has worked in improving the mortality data and has been recognized internationally by the WHO, and it has received the WHO Excellence Award at the World Health Assembly for significant advancement in national mortality data. Based on the findings from this data, we were able to understand the causes of mortality. So we have calculated the non-communicable disease SMR. That is an important public health indicator that involves cardiovascular diseases, cancers, diabetes, and chronic respiratory diseases. In 2022, the Kingdom of Saudi Arabia has 510 deaths attributed to non-communicable diseases per 100,000 individuals. By comparing ourselves with the G20, we ranked the 15th. So to guide our national target setting, we have looked closely at the regional NCD and SMR, and the rate of 324 was chosen as the Kuwait. It was the first country in the GCC. So now we have 510 deaths, and we have a target to reach with the 324 in 2030. So we came up with our most important initiative, the high impact interventions to reduce NCD SMR, which we call the 324 plan of the Saudi Public Health Authority. It's a multi-sectorial plan that tackles tobacco use, unhealthy diet, physical inactivity, obesity, diabetes, cancer, and chronic and CVDs, cardiovascular diseases. So by the work that has been done and the mortality data, an extensive analysis was conducted of the risk factors that contributing to the NCD's mortality. And 3 priorities areas came up: hypertension, diabetes, and tobacco use. Why we chose those 3 priorities? These priorities accounted for 70% of the NCD's mortality in the kingdom. International benchmarking and global success stories confirm that target interventions in this area yield a rapid and measurable improvements. So to accelerate our progress, we adopted a structured approach grounded in the 90-90-90 methodology or strategy. This was used in the HIV pandemic to control the pandemic. And this 90-90-90 means that 90% of individuals who are having hypertension or diabetes being aware of their diagnosis through expanding screening. Then 90% of those started treatment, and 90% of those on treatment being controlled and have a good health outcomes. So the 324 plan is built on the foundation of multi-sectorial collaboration, and by doing so, we strengthen not only the health of our population, but also resilience, prosperity, and well-being of the kingdom. In doing so, we honor the vision of our leadership and advance the goals of the Vision 2030. Thank you so much.
Thank you, Dr. Ayman, for your valuable insights. And now we would like to move to our first session. Our first session is entitled National and Regional Strategies for Tackling Diabetes. This session will be led by the moderator, Dr. Ahmed Ismaili, an endocrinology consultant and a chairman of the outpatient department at King Abdulaziz Medical City in the Central Region, head of the Division of Endocrinology and assistant professor at King Saud bin Abdulaziz University for Health Science. Dr. Ahmed, the floor is yours.
السلام عليكم. صباح الخير جميعا. Thank you first of all, for you all to come today in the morning, Saturday, over the weekend. Thank you for the organizing committee. For the past few months, they did great effort to organize this meeting. Thank you again for the committee to invite me to chair first session of the meeting. So first session will be national and regional strategies for tackling diabetes. Prof. Khalid Rabi'an, he will be our first speaker. So Prof. Khalid is a full professor of endocrinology and internal medicine, working currently as director of research and scientific center at Sultan bin Abdulaziz Humanitarian City, former head of University of Diabetes and Strategic Center at for Diabetes Research, a part-time WHO consultant for regional office for the Eastern Mediterranean region, EMRO, and the chairman of board of TUSTI and founder of Diabetes Science International Foundation based at Switzerland. So welcome Dr. Khalid Rabi'an for the first session and first presentation. Thank you so much.
السلام عليكم. صباح الخير جميعا. In fact, it is really a great pleasure for me to be here, and I feel even proud that this meeting is headed by one of my smart students who is now taking care of the mission about diabetes in the kingdom. I would like to tell you that it's been always an honor for me to speak about this problem, although I have very long experience. I'm talking about almost 40 years, so you can imagine how old I am now. So, but I have lived this disease when it was only 2%, when I was a medical student, and we conducted the study in Al-Majma' area. And at that time, Professor Abu Aisha was chairing that survey, and it was only 2% in Al-Majma' area. Now you can see we have almost reached 10 times of that prevalence, unfortunately. And honestly, when Mut'ab invited me and the organizers who have really organized this wonderful meeting asked me to speak about what happens 100 years back and what is the future. In fact, I've been even writing a review now on the white paper for WHO about the area, the MENA region, and where is diabetes going in the area. And I'm going to show you data, but let me tell you, it's a disappointing data. And unfortunately, the disease is winning and we are losing. And I'll give you some figures, and then we'll come up with very beautiful plans that I have heard over the last 2 years, in fact, on managing this problem at a national level in Saudi Arabia, and I hope also this will happen in other countries. Let me start with this. This is an overview of what has happened globally on managing diabetes. You can see from the data in the figure here, I think the laser is not showing. You can see the orange area is speaking about the phase before oil was discovered. And then the red area, when there is a lot of studies and a lot of medication which have really come to diabetes. If you see from the discovery of insulin in 1991 until 1996, we have only insulin, unfortunately, although metformin have started, but not that much. Then you can see between 40 years until 2000, we are speaking about most of the discovery of other oral agents, technology, diagnosis of the disease, hemoglobin A1C discovery, glucometers, and the developments. Now, I have to tell you, after 2000, we start to put more weight on technology. So now you see a lot of technology growing. And I'm going to show you the effect of technology on both prevalence, incidence, and also mortality. Did this technology help us, or we have to go deep in the mind of a human being trying to change the behavior? I wish there is a tablet that someone can really develop where we can give it to the people so they behave properly. They stop when the light is red and move when the light is green. But unfortunately, this tablet, I don't think it's going to see the future. Now, look at how much medications. When I was a medical student in the late 70s, there was only 2 types of insulin: the regular insulin and the MPH, which where people call it Safi wa Akir. Now, if you go, there is more than 40 types with different combinations and so on and so forth. So the drug availability and the technology and the investment and the innovations have really made managing diabetes easier. But then the question comes, did this make a difference when we speak about the outcome? To convince you that this is not the story in the kingdom, but in fact in the whole globe, the oil discovery started from 1940, reached the maximum in 1960s. Look at the GDP, how much the people are earning globally. It was almost flat before the oil era. When the oil started to be discovered from different parts of the world, things are really climbing up. But then in 1960s, the GDP in most developed countries, I'm not speaking about developing countries, have really increased markedly. What you are seeing is developed, or the Western countries, although the black line is showing you the global GDP. This means that there is something happens to the human people, to a human being, that have led that their income is increasing. Now, this is very important because this is now linked to most of the chronic diseases we are seeing these days. So although it has started in the Western society, by the time we reach to that phase, we've been even affected. Now, this have changed our lifestyle. Just imagine if the oil was not discovered 60 years back. Do you think diabetes will be the way it is behaving these days? I don't think so. And there are some documents which have shown that certain areas where they were not affected by urbanization, still they are running at a rate of almost 1% or 2%, especially rural Indonesia area. And they are used now as a model to compare. If you want to select a clean, you can call it, a society that has not been affected by the lifestyle. So I want you to keep this in mind because I'm going to take you through this different phases. We started between 1960s and 1985 with a low incidence of diabetes. I told you, in Saudi Arabia it was only 2%. Dr. Fatani and Siraj Mira in Jeddah in the early 80s have found that diabetes is only 5% in Saudi Arabia. But then we came after 10 years, and then we discovered that it has jumped into 12%. So the era between 1960 to 1985, low incidence, steady diabetes growth. It was not really very obvious. And there is high incidence, but it was not visualized. But I can tell you, the diabetes was poorly controlled. The care which was given to the patients are really very limited. And I was just spoken this morning to some of our colleagues. You have to know that in the 70s, in the late 70s, there was only 2 diabetes clinics in the whole kingdom. And you can imagine what is happening now. So things really went from 85 now to 2010. We start to understand the disease. Medical care become better and better. And then we start to pick up the complications. We start to see the complications. renal failure, eye complications, neuropathy, amputations, and so on and so forth. But there is something which is very unique also. We start to see type 2 diabetes, which is adult onset diabetes in young population. And this is something very serious. This means that those who were diagnosed when they are 40 or 50 with type 2 diabetes can live up to 90 with no complication. But imagine someone who is only 15 years of age and now he's type 2 diabetic patient. So you can imagine what sort of burden it will be. Now, between 2010 to 2020, there is no question that prevalence of diabetes have almost increased very badly. The strategies of complication screening has improved, and we are catching more. But in fact, there is a shift, and I'm going to show you a figure. There is a shift of the burden of the disease from old age to young age, and I'm going to show you this because it is very important. Now, we are supposed to reach to Vision 2030, and longevity is one of the issues the country is trying to really work hard on it. Believe me, if we didn't start with the chronic diseases, we cannot really improve longevity. I have to tell you, the lifespan of Saudis 30 or 40 years back was 53 only, and now we are 70 plus. I strongly believe that diabetic patients are living longer, but with a lot of agonies and complications. And for that reason, I'll take you to the next step, which is the WHO, highlighting the most important serious issues. And I'm just only showing you this slide to really pinpoint that there is increasement in the incidence, in the prevalence, in the rate of complications, and also in the cost of the disease. And WHO keeps throwing warning signs to push country of states to really take proper actions to try to really control this disease. Now, this is another just a beautiful example of what we can do and what the scientific literature is saying. You can see from this figure that if you encourage certain cohort to eat healthy diet and to practice proper physical examination and daily physical activity, you can reduce the rate by almost more than 40%. And this has been really proven to be true. Like, for example, the Australian prevention program, the Chinese type 2 diabetes prevention program, and other prevention programs. There is very clear success there. But unfortunately, when you go and do an overview and review, and this is what I'm doing in my white paper, trying to see, did these programs have really affected the overall disease pattern? It may have improved individual lifestyle and health condition, but unfortunately, it didn't. Now, let me give you an idea of type 1 diabetes. I still remember when we really started registry in 2000, which is called Diamond Project. At that time, the rate of type 1 diabetes among Saudi children was 20 per 10,000. And you can see from this figure, I think I have highlighted Saudi Arabia to be one of the high-income countries, and you can see how much we have jumped. We are almost not that different from the Western incidence rate. Now, why is this? Why our children now are affected by type 1 diabetes? I can understand type 2 diabetes in young people to be related to obesity and high calorie intake and low physical activity, but then you have to ask yourself a question, why? Why type 1 diabetes is also increasing? So there is something beyond these lifestyle modification factors that have really led to this autoimmune to really penetrate the community more and more. I think we are seeing more type 1 diabetes for two reasons. Number one, the incidence is increasing. Number two, that we are still young population. And there we have more children. We have more than 40% of our population less than 20 years of age. This is something serious, because if you see even down there in the bar side, this is the lifespan. This is another issue. with the good care, medical services, those type 1 diabetics are living longer. But believe me, they are also inheriting or inhabiting certain complications within their lifespan period. This is just to show you, we are supposed to be with the high income countries, and you can see that the younger you are, the higher the incidence on the right side. But also look at the poor countries also. There is also increase in the rate of type 1 diabetes, even when you are talking about these very poor countries. Now, can we explain this? I think there is a lot of hypotheses. One of the hypotheses which I found it very strong in the literature and needs a very clear and deep study is basically microbiome, the bugs inside your gut. This is true also in other non-metabolic diseases. I'm sure you agree with me, those who are practicing, we are seeing more Crohn's disease than before. We are seeing a lot of ulcerative colitis, which was not there. When I was teaching in the 80s and in the 90s, we rarely see a Saudi with Crohn's disease or ulcerative colitis. Go now to the emergency room, unfortunately, it is more and more. This gives the clue that these bugs, as you can see, can trigger certain T cells that can really produce the antibodies. And it's not only affecting the gut membrane or tissue, but also it can pass to the blood and go to the beta cell and lead to destruction of certain cells like beta cell. So this theory is still a theory, but it could be true. We need to have more and more studies. Let me tell you, one of my studies I have done was to look into the microbiome of the mouth. And I have taken normal people, impaired glucose tolerant patients, and diabetic patients. And believe me, we have found a significant difference of certain bugs that are really inheriting the oral mucosa, mouth mucosa for diabetic patients than non-diabetic or impaired glucose tolerant. So this theory is strong, but is it behind the whole things? I'm not sure. Now, this is a radar figure, just to try, I'm trying here to summarize to you, what do we have, in fact, when we are really thinking about controlling diabetes. We have to control body weight, we have to control daily activity, we have to control calorie intake, and then we have to make sure that if someone is having diabetes, that his hemoglobin A1C and blood sugar is at the same level. These figures are from an average, which I have collected myself from many literature from Saudi Arabia. The red is what we are, the blue is what we should. You see how far we are now. We are really, unfortunately, a very small group inside the radar are really controlled, while the majority of diabetic patients are not really controlled. And this is true also in other countries, unfortunately. But I think we have to work hard on this. Now, let me tell you one thing we have done as a scientist when we are really sometimes taking decisions. You remember in 2012-13, there was a new American Diabetic Association guidelines, criteria, that we should screen diabetic patients by hemoglobin A1C. You remember this. And I still remember being a member of WHO who sets some of the criteria for diagnosis of diabetes. We usually rely on fasting and 2 hours post-branded or glucose tolerance test. But because we are looking for the cost effectiveness, we said, let us try to see if hemoglobin A1C is going to be cost effective and can diagnose patients. And believe me, this has led to a complete mess in understanding the disease. Look at the figure. We have a flattening, as you can see, on the incidence. This flattening is false. This is because we have used hemoglobin A1C as a diagnostic screening test, which means that you could have a normal hemoglobin A1C, yet you are showing some impaired glucose tolerance phase, unfortunately. And as you can see, this has affected not only the overall, but also any age group, as you can see. The red line is for the old people, the middle age, and the young age. And unfortunately, you can see the drop, which we are seeing, is a false drop. It's not a real drop. This is because of our diagnostic criteria when we did a mistake on this. And this have really made some of health advisors and key leaders to think that we are really controlling the disease, but in fact, unfortunately, the disease is there hidden because we did not use the right tool to diagnose it. This is one of the things I would like you to go home with. This is very important because this slide I have made myself, and I have looked into different years, 1980, 90, 2000, 2010, and 2020. And I looked into the mean early detection of the disease. You can see with the years, we are picking the people early. In the past, we picked them up after 40 years of age. But now you can see around 30, we pick up the major cases at that time. Now, if you go and look into the mean diagnosing age, it's also shifting to the left. So we are catching people earlier. But if you see when they are going to die, you can see that diabetic patients are doing better. Before, the mean age for diabetic patients in the 80s was almost 67, I remember, or 65. But now they are almost exceeding 70. They are almost equal to the normal people. Now, what is something I have to really also tell you, look at the mortality curve distribution. Look at the peak. In the earlier time, it was on the right side. But while we are really moving and having a wider spectrum of those diabetic population, we are shifting to the left. What does this mean? This means that some of our diabetic patients are dying early, and they die because of serious diseases. And I'm going to tell you that it's not cardiovascular disease, unfortunately, because it seems that cardiovascular disease is picked up early, managed properly, stenting or bypass or whatever, so they live longer. They bypass the condition seriousity, but unfortunately they die because of something different. So I would like you to really keep this in your mind, and especially our colleagues from CDC, that yes, we are seeing them dying early, and unfortunately, that this is something we can really prevent. But look at this. We have improved the care that have really given them better chance, but unfortunately, we are seeing them dying earlier. This is just, again, to confirm that the mortality is the same. And I just want to show you that the high-income countries, they have the best mortality when you compare them with them. This is just only to take you to another figure, which I'm going to conclude my findings later on, that the percentage of changes in the number of deaths in type 2 diabetes between 2020, you can call it, in 10 years. Look at them. The older, you would expect them to die more, but unfortunately, the death problem started from 15 to 50. Look at the middle group. This is unfair that people will die there. It is more in type 2 diabetes, as you can see. And also, unfortunately, look at the Mediterranean region. We are one of the hot areas, unfortunately. When you compare us, for example, with other countries like Americans or the Western Pacific. So we are in the wrong spot. We are also having the wrong age and so on and so forth. This is how things in different income countries. We belong to the high income countries, but you can see that even if you have money, this cannot prevent you from having high mortality. This is the life expectancy. This is what we are trying to do and work hard for. Look at some countries where they have reached almost 80. I think we are now around 70, but I think with the hit of the wave of diabetic patients, I think we are going to plateau, unfortunately, unless something is going to be done. And again, I want you to notice that the peak, the improvement in life expectancy, lifespan, have really started after the oil discovery, which makes this prosperity. I want to tell you, if you ask me, which one really gives the best management for diabetic patients, honestly, oral agents, insulin, they really control the diabetes. But can they improve the patient's life? Yes. Or lifestyle? Yes. But can it really prevent serious complications? The answer is, unfortunately, is no. We are still seeing a lot of renal failure, and it has increased that much. This is the data which we didn't publish yet. We are going to publish. This is from Saudi National Bariatric Registry, which we are hosting at Sultan bin Abdulaziz Humanitarian City. And I want to see how much remission of diabetes we had after bariatric surgery. 70% of them return back to normal, and another 20% have really minimized their medication, which means 90% success. This is one of the best management I could really think of. So I think this is one of the markers that we have to keep in mind. This is not to mention that there are some future medications that we are hoping also that it will really show. This is what the WHO published in 2013, and then they put these guidelines. You can see how much they were reduced from, for example, body weight, daily activity, smoking, alcohol consumptions, and different guidelines. I think they are familiar to most of you. Now, 10 years after this declaration, which was distributed to all countries, this is the outcome. Unfortunately, we even didn't reach 50% of that target. We have reduced, for example, premature mortality by almost 25%, alcohol by 10%, insufficient physical activity we have reduced by almost 10%, and so on and so forth. So this is my last slide, but I would like to conclude that yes, we are living in a luxurious time, and we are really very relaxed, but things are really changing in a way that pushing us to diabetes, whether we like it or we don't like it. Believe me, these days, if your wife or your children ask you to buy something from the grocery, before you take the car, at least you walk and then you go and you buy. Now you don't need. You can ask Jahez and he will bring it to you. So I think things are really becoming so nasty and very bad. Not to mention that every Friday, my sons usually gather in my house, and everybody comes with all these types of chocolates, and this is part of our culture, which was not there before. Before, when we are gathering, I remember when we were children, we go and play. But now we gather to eat, unfortunately. Thank you very much.
Thank you, Prof. Khalid. It's a great presentation. So our second speaker will be Dr. Mut'ab Al-Utaibi. He will talk about the new Public Health Authority guideline for diabetes. Dr. Al-Utaibi is a consultant in endocrinology at University Diabetes Center, King Saud University Medical City, and Program Director of Diabetes Fellowship. He also serves as consultant in endocrinology at Dalla Hospital. He is one of the authors of 2025 Public Health Authority Saudi Health Promotion and Prevention Guidelines for Diabetes. His research and publications span diabetes technology, glycemic patterns in type 1, obesity therapies, and chronic disease epidemiology. Join me to welcome Dr. Mut'ab Al-Utaibi.
Assalamu alaikum. Good morning again, and this is the beauty of delivering to lecture. You receive, you will be presented twice, so I will keep that. Now in the coming 15 minutes or 20 minutes, we'll speak about Saudi health promotion and prevention guidelines. This is published by Public Health Authority, and with the colleagues review and help in the writing of it. And just recently published, and I hope our country and healthcare providers will get benefit from it. As mentioned by Prof. Rabi'an and colleagues, and it's now a national priority. Diabetes, it's not an easy disease. It's affecting all our population. We need guidelines and unified care for our patients. And our care, not either to prevent or control. We need both. We need to prevent diabetes. We need to control who we are affected by disease. And I would speak about all types of interventions we could do for our patients. I think, as mentioned previously, diabetes is epidemic disease in our country now. It's not easy things that we could deal with it. And its main substantial burden from communicable disease, as discussed by Dr. Ayman. And unfortunately, uncontrolled diabetes will lead to different complications, microvascular, macrovascular, and other metabolic complications. Generally, diabetes is preventable, especially type 2, GDM, and now we had effective therapy delaying maybe even type 1. Unfortunately, different countries, we are facing almost 20 to 30% undiagnosed or 40% undiagnosed diabetes. And we have a target goals that we want to alleviate the burden of diabetes. So the scope of this guideline and the objective that we need to effectively help in diabetes control and prevention and ensure a standardized screening of the complications of diabetes in our country. And this is for all age, adult, pediatric, and children, and adult and pregnant women. And you want early detection of diabetes. We don't want to discover diabetes once the patient presents to the ER with the MI or the stroke. Of course, because the guideline, we discuss the rare form of diabetes like Moody or others, it's not discussed in this guideline. As you know, prevalence of diabetes, we are approaching around 23% of diabetes prevalence. And that expects around 5.3 million in our country now. And undiagnosed, 43%. It's undiagnosed diabetes, and it's a huge percentage. It's unfortunately similar to advanced countries like UK and USA. They had some similar figures of 40% and above undiagnosed. Our target in the near future should be lower, and we need to work together on it. If we do nothing, if no intervention, we expect in 2050 to reach 9.5 million with diabetes. So we need to act now to fight diabetes, or we will face bad situation in the near future. I think one of the golden area of interest for us and for Wiqaya is the pre-diabetes. Maybe colleagues from WHO don't address pre-diabetes term, and they are not in favor of pre-diabetes term, which is we need. We had a huge percentage of pre-diabetes. We have 27% with the pre-diabetes. We are a nation of diabetes and pre-diabetes. And there is old view for Prof. Rabi'an. He said, normal people we could work with, people diagnosed with diabetes, they have diabetes, it happened. The golden area for us is the pre-diabetes. Only 5% weight loss, 5 to 7% weight loss, back to normal. Lose 5 to kg is easier to lose weight in normal people or with the pre-diabetes. If people have diabetes, and I think Dr. Ali Shiri will speak in his lecture, difficult to lose weight with diabetes. So the golden area for us to fight diabetes is pre-diabetes. 5-10% weight loss, metformin, lifestyle change, back to normal, then it's really, at least for our nation, pre-diabetes is golden area. We need to fight diabetes early before it happens. So pre-diabetes, unfortunately, in our nation, 27% without intervention, 10% progression annually. By lifestyle modification, we reach to 58% risk reduction. So we need to speak about it. As you know, now, as mentioned by Prof. Rabi'an, that adolescent and young adult, we see young people with the type 2 diabetes. Unfortunately, we are facing this dilemma. In the guideline, we had some figures, some tables. I will not discuss it all. We try to help how to generally differentiate between type 1, type 2. Unfortunately, there is a comment. Age and obesity, it's not always differentiate between both. We are seeing type 1 in 15 years. We are seeing type 2 in 15 years. We could see type 1 in 60s, 70s. So it's not only weight and BMI or obesity or age. We are seeing this. So these figures or tables will help us to diagnose our patient. We need to look risk factors for diabetes. If we speak about diabetes type 2, we have modifiable obesity or overweight, sedentary lifestyle, or unhealthy diet. We could speak about smoking, and even passive smoking increase the risk of diabetes, hypertension. We could do nothing with the age. We cannot family history or genetics, but we had modifiable risk factors. If we speak about type 1, as mentioned, it's surging nowadays. We are seeing higher cases of type 1 diabetes in our country and different countries. Genetic plays a significant role. Infections, different infections, they may have rules there. As mentioned in one even of slides for Bayan, obesity may contribute to increase incidence of diabetes, but for sure it will complicate the management of diabetes in type 1. They will have double diabetes with the obesity, so it's challenging to manage obesity with type 1. Gestational diabetes type 1, it's unfortunately neglected, and many women with pregnancy, they don't do the screening for gestational diabetes. Then diabetes will persist with them and complicate the pregnancy and for the mother and for the fetus. Again, the risk factor, obesity, maternal age, as get pregnant, get married late, pregnancy at later age increase the risk of diabetes. History, risk factor, prior GDM, macrosomia, or family history of type 2. I think this is all the guidelines screening for asymptomatic. Anyone symptomatic, for sure we'll screen him. One of the good things that previously the guideline recommending screening at age 40, Saudi Arabia, one of the early countries that says no, we need to screen 35 years old and above. But also anyone with risk factor for diabetes, screen him. From age 18, if he had obesity, please screen him. Whatever the modality for screening, we had different modality. All pregnant women deserve screening for GDM, and that mainly by OGGT. If there is a prior history for GDM, we need to screen them after pregnancy, from 12 to 12 weeks. After pregnancy, we need to screen them by OGGT. So the guideline is clear about that for asymptomatic. Asymptomatic, for sure, we will screen them. Why we target early detection? For sure, easy, simple, easy things. Diabetes is reversible. If I have pre-diabetes by 5%, it can be a good situation. Type 2 go in remission. If we detected diabetes early, especially in the first 35 years, usually bariatric surgery will lead to remission. Significant weight loss will lead to remission. But at that time, we need 10 to 15% of the weight loss to put diabetes in remission. In pre-diabetes, it's enough for us to lose 5% or 5 kg to go to remission. Better outcome of GDM. In regard of type 1, now evidence evolving. We had evidence showing that less DKA at presentation for those we knew they are in pre-diabetes, early stage of the pre-diabetes type 1 diabetes. We can delay type 1, 2-3 years. For sure, we had strong evidence because the family are aware about the history and the symptoms. We could prevent DKA at presentation and maybe improve glycemic control. So our target to prevent diabetes across all ages, all stages of diabetes. We had a primordial prevention, we have primary and secondary and tertiary, and we have to act in all scope for prevention for diabetes. Primordial prevention, in this we are target healthier people to behave better. We want to prevent diabetes, we have to prevent obesity, so they will not get diabetes or pre-diabetes, and that's simple. by change some behavior, change their lifestyle, maintain healthy weight. That's enough for us to maintain healthy situation. Then we move to primary prevention. This is for people with pre-diabetes. Pre-diabetes is a golden era. Just simply 150 minutes and exercise, lose 5% of their weight. If we need, metformin is there, effective, cheap medication we can utilize. And especially in DBB trials, they look for those with a prior GDM or BMI above 35 or A1C seem to be more than 6%. Those we have to concentrate on them. And secondary and tertiary. Secondary, those affected by diabetes. Affected by diabetes, let's to work to control diabetes. Why? We want to prevent complications. And good control, confirmed by trials in the past, confirming good control of diabetes will prevent or delay complications of diabetes. Then we'll move to tertiary. If patient with diabetes and nephropathy, at that time we want to preserve kidney function. We don't want renal failure. We want to prevent cardiovascular disease in those. Now this is the tertiary. So in all stages of diabetes, we will work with our patients. We hope to be in early stage to control and help them, but in all the way and all the road, we will work with our patients. About type 1 prevention and emerging therapies, we knew that there is primary, we could do screening and genetic, may be expensive nowadays, but there are some genetic programs, especially in the countries with high prevalence of diabetes, we could work and first degree relatives screen them. And secondary, once the patient has stage, we have identification, he's in stage 2 diabetes, type 1. Now, this is not addressed in the guideline, we comment on it. Tibrizumab now recently approved by Saudi FDA in this stage. Then tertiary, patient already have type 1 diabetes. We want good control of diabetes. We want to prevent complication. Again, we comment clearly that universal screening remain a long-term goal. But considering that 85% of the patient are unknown family history, this is now there are some RCT, there are some trials in type 1, and there is advancement in the care and trials on type 1 prevention and control. But all days we speak about glycemic control. That's not the situation nowadays. We are speaking about cardiovascular, renal, metabolic care of diabetes. We'll speak about hypertension. We'll speak about dyslipidemia. We are not speaking about glycemia because evidence showing to us we need to control all cohesive control, many complications. We are not targeting glycemia only for our patients. Weight management is essential. We have a lecture maybe in the second session of Dr. Ali Shehri, but for sure that sustainable 5 to 10% effectively helps control. If we are target remission of diabetes, we need 10 to 15% weight loss, but that's really challenging, especially with diabetes. We have dietary structure, behavioral, we have pharmacotherapy, GLB, GIB medications now available. We have bariatric surgery. But we speak always, multimodal approach is a target. Multimodal, sometimes we need lifestyle change in addition to medication, or medication in addition to bariatric surgery. So we could utilize multimodal approach in specific patients. We had evidence from direct trial about lifestyle change. We have DBB trials showing how the lifestyle is effective in management of patients with diabetes. We have different diet, Mediterranean, DASH, plant-based, low carbs. But the study showed to us adherence is more than important than the type of the diet you are on. Whatever the diet the patient on and he's happy, he can continue. But the adherence to the diet more effective more than the type of the diet he is on. I think now we are in the era MASLD, previously named NAFLD or MAFLD. We need to screen diabetes care. We look for diabetes, hypertension, dyslipidemia. We had some non-invasive risk stratification. We have for helping us who's high risk, who's low risk, who intermediate. In both intermediate and high risk, we need to refer to gastroenterologist or specialized person who's interested in this MASLD. And it's now era maybe not recognized by WHO as a disease till now, but maybe in the near future. As mentioned, diabetes and glycemia. We spoke about hypertension, diabetes, osteoporosis, many. So the clinic, you don't need a longer duration with your patients. Osteoporosis patient with diabetes at higher risk for fracture. And especially the longer duration or poor control. We had many ways to screen for osteoporosis in our patient. In addition to the DEXA scan or FRAX or whatever, then based on the situation, we could manage him. Type 1 diabetes is really not challenging situation. Patient type 1, in addition to type 1, they are at risk for other autoimmune disease. TSH, hypothyroidism is high common in them, but also we have to remember celiac disease or adrenal insufficiency. We have to be aware of this complication in patients with type 1. If we spoke about population health, population level policy intervention need significant intervention. If we spoke about environmental design, we need area for people to walk. We should have built pedestrian friendly. The people can move in the street. We have to have recreational centers. We have to encourage physical activities in general. We have to regulate food composition. We have to regulate, implement food front-back labeling. We need to restrict junk food and maybe the timing, raise the tax on it. We need tobacco banning. We need even restriction of shisha outlet availability. It's nowadays we see it in many places. We need to restrict it. Unfortunately, they name it now lounge. In the old days, naming shisha, it's now lounge. We need really to put restricting on it. We need to expand screening program. People in Riyadh, like people in Rafha, like people in Jizan, Najran, in peripheries, they deserve to have access to screening, and it's affordable for them. And we need to improve it. We need mass media campaign. People are now listening to the media. We need to go to the people in the media, educate them about diabetes, about their screening way and how to interact. We need to educate patients for self-management of diabetes rather than keep them visit the clinic to receive the care. We need to support a networking group, personalized management. We need behavioral incentive. And we mentioned that we need financial support. Why people with diabetes want to go to the gym should be with the discounts specifically to the people with the pre-diabetes or people with diabetes. And we encourage that in the guideline. We also address the limitations we have. We mentioned that clearly. In our country, we have diagnostic challenging. And diagnostic challenging, sometimes people screening program, maybe not everywhere you will find that. It's not easy for people in some area. They will not find what target for the screening for either diabetes or its complication. We are now that maybe monofilament not available for screening for neuropathy in some primary care. There's a prevalence of diabetes huge, so they will go to primary care. We need to be that test like monofilament should be available. And we have some patient stigma. Some people, they don't want to be screened. They are worried to be diagnosed with diabetes. Management barriers. We are sure that sometimes we don't have glucometer or we don't have limited access to the specialist. We think that all people, at least in GB, they should be good knowledge about diabetes, advanced care referred to specialized people. With availability of cardiovascular prevention medication like GLP-1, GIP, or SGLT2, it should be available for whom deserve this medication. We knew that some clinical assessment limitation. We have inadequate trained programs. We need the programs that everywhere for any patient with diabetes. We had a few tertiary center for advanced care, and we need multidisciplinary educated people to deal with diabetes. We have limited continuing medical education CME hours in that regard, and sometimes the guideline not implemented everywhere as we hope. We had variation in health delivery. I hope that people in Riyadh coming to University Diabetes Center or Takhasusi or King Fahd Medical City or National Guard, they receive the care similar to the others in peripheries because we have unified the system and available for all people. And sometimes in the old days we speak, sometimes we need to unify, centralize that we have electronic health records. So I know I need data than in other places. Maybe Nafis nowadays evolving. I hope it will be successful. Unfortunately, we are relying usually on the data from outside. We need our National Diabetes Research Committee, and we see what our need as a nation for diabetes, rather than inherit research coming from Western country and we apply it in our nation without realize it's for us. Maybe Professor Be'an from his research center will comment on that. We could do in that. Maybe Public Health Authority, what the requirement, what we could do. For strategy priorities, we need a national screening program, and so that should be implemented for type 1 or type 2 or whatever disease we need for that. We need unified electronic system. We had NFIS nowadays. Once it's applied, I think it will help us a lot. We need to improvement access to the tools and specialties. And we have Saudi focused for diabetes research for our nation. Finally, I will comment that we are target from this guideline and from the work from colleagues from everywhere for diabetes, building a healthier future for diabetes. We are a nation with diabetes, so we deserve to be leading the countries to tell them what we could do for diabetes. How could we fight diabetes? We had the brain, we have the we are ready to proceed with that. We should do our research in our patients. So for that, our time for action for diabetes is now. Thank you.
Thank you, Dr. Mutaib, for a great presentation. So as we are moving now to virtual care and telehealth care, mainly in diabetes with the help of new technologies. So our next speaker will be Dr. Abdullah Al-Wabil, who is specialized in endocrinology, diabetes, and obesity. He earned his MBBS from King Saud University and completed his the Saudi Board of Internal Medicine. Dr. Al-Wabil pursued advanced endocrinology training through an Australian fellowship and specialized studies in diabetes and obesity at the University of Melbourne. Dr. Al-Wabil will talk about revolutionizing diabetes management through virtual care, opportunity and challenges. Welcome, Dr.
السلام عليكم. صباح الخير. I would like to thank the scientific committee for inviting me in such great event today. And I will talk about the revolution in diabetes management using the virtual care. My objectives today is to give you a brief about telemedicine background and some definitions, and to give some idea about international experience and as well local experience, and to talk briefly about the major challenges against the implementation of virtual care. The Arabic scientists usually say لا مشاحة في الاصطلاح. So, but to give you just a clue about the telemedicine definition, it's the practice of providing healthcare services remotely, allowing patients to consult with healthcare professionals from distance using digital communication technology. So basically, we need communication. We need the communication tool and medical application, and for sure that it will open the gate for the health practitioner to see the patient. So telehealth, when we include non-clinical services like education, this is will be defined as telehealth. If we use more advanced technology, so this will be virtual care. So, sorry, I'm trying to use the monitor. Because it's green. My presentation is green as well, sorry. So in summary, telemedicine, telehealth, and virtual medicine are all related to the remote delivery of healthcare services, but they have distinct focus and application within the digital healthcare. International experience, we will see some research evidence. What about the patient satisfaction, and what about the global implementation? So in this study, you can see it's a prospective cohort study done on 115 patients in USA, and there was significant hemoglobin A1C. The A1C dropped from 9.5 to 7.9. This is another study, which a comparative study of diabetes consultation versus diabetes self-management education delivered through telemedicine platform, done on 69 patients. It was prospective cohort study, and you can see there was a drop of hemoglobin A1C from 9.3 to 7.2. And the other program also dropped from 9.8 to 8.3. So this is another program using the video conferencing consultation to manage patients with diabetes, and it's a large-scale program connecting the rural patient with primary care provider for comprehensive diabetes management. And you can see it's done on huge sample, more than 9,000 patients. And the result was the V-Impact care showed comparable or better outcome in medicine adherence and testing compliance. So it's not inferior, it's not superior, but at least it's not inferior. This is another study done on the secure messaging patient portal. So it was a digital communication platform enabling secure messaging between patient and healthcare provider for diabetes self-management support. It's done on 1,000 patients. It's a retrospective study with mixed method approach, and the result was higher secured messaging using associated with 1.5 higher odds of hemoglobin A1C control. This is another program. It's a diabetes care network program. It's a comprehensive remote diabetes management network designed specifically for rural patients requiring intensive glycemic control support. It's done on 87 patients. The study was prospective cohort study, and you can see the hemoglobin A1C reduced significantly from within -3%. This is another study titled with Tradition Telehealth Visit, and it was a standard telehealth visit for specialized endocrinology care focusing on type 1 diabetes management in rural population. The sample size was 139. It was a retrospective cohort study, and we can see there was dropping or improving of hemoglobin A1C from 8.4 to 8%. This is another program called ACDC program implementation, and it was Advanced Clinical Diabetes Care Program targeting clinical refractory and controlled type 2 diabetes patients with mixed method approach. It's done on 230, and we can see the ACDC, the result. The ACDC demonstrates significant glycemic improvement
and confirmed telehealth feasibility in the rural setting. Not always the telemedicine or telehealth for physician, also other health worker practitioner can participate, and this study done with pharmacists, telehealth diabetes management program delivered by pharmacists, specifically designed for the patient with diabetes in the rural setting. It done on 522 patients, and you can see 72% maintained hemoglobin A1C control, 12% improved their glycemic control, and only 15% experienced worsening outcome. This is another study in endocrinology care comparison. It's a comparative analysis of telemedicine versus in-person endocrinology care in both rural and urban diabetes management setting. Large sample, 3,700 patients. Telemedicine only found just no improvement. Not always telemedicine is a good tool, but at least it was not inferior. You can see the telemedicine only less effective, mixed in-person care improved, hemoglobin A1C, especially for rural patients. This is another study, 400 patients. You can see hemoglobin A1C dropped from 7.9 to 7.3. So just to summarize some of the study, you can see a lot of study with different study sample, and you can see effective, significant reduction, equal effectiveness, improved self-management, and the program here is get success. What about the local telediabetology experience? We done a study in King Saud University in 2019. It was rapid implementation of diabetes in telemedicine clinic during the COVID crisis, and we can see there was most of patients before the COVID crisis. We think that patients will not accept or they will not feel comfortable to use the telemedicine or telehealth. However, we can see that in this study, 97% of the patients found telemedicine essential for maintaining glucose control during COVID crisis. This is another study titled with the perception of virtual clinic among Saudi adults with diabetes type 1 during the pandemic. You can see the result. We can see that showing that 60% of type 1 diabetes patients expressed more satisfaction with virtual phone consultation for routine diabetes follow-up. However, 22, they think it was not a good service. This is very important study about the cost effectiveness of telemedicine care for patients with uncontrolled type 2 diabetes. You can see the result that there was 18% cost reduction. So the study demonstrates that telemedicine provides comparable or superior cost effectiveness for uncontrolled type 2 diabetes. This is another study used the application to deliver virtual follow-up care for children with type 1 diabetes, and this is very important to assess how the family will accept virtual care for their children and for their children diabetes control. And we can see that more than 35, they were completely satisfied, and 28 satisfied, and somewhat satisfied is just 16%, and not completely satisfied or even not satisfied is just 10 to 11%. Yeah, so I just will talk about another great project, different experience, which is Sahha Virtual Hospital. You may know that Sahha Virtual Hospital founded in 2022 this is the official launch, but the hospital or the services of the hospital started before that during the COVID crisis and pandemic. We are currently connected with more than 33 hospitals across the kingdom, and we are providing a lot of services from tele-ICU, tele-radiology, tele-stroke, and as well outpatient services with more than 70 general specialties and more than 41 subspecialty. We are served more than 400,000 patients, and we give more than 60 million consultations through 937 hotline. And you know, during the crisis, the consultation reached up to more than 30,000 or even 40,000 consultation a day. So this was huge, huge services. And we proudly get Guinness record as the largest virtual hospital worldwide. So in diabetes services particularly, we providing more than 8 specialized clinics with some advanced care program. It's 24/7 and it's 100% virtually. Regarding some advanced virtual diabetes care program, we do have virtual insulin pump clinic, and we do have remote glucose monitoring, and we established this program for Hajj last year and the year before the last year. And Prof. Khalid talk about diabetes remission. We try to do some weight reduction program. You know, now diabetes management is mainly weight-centric approach rather than glycemic-centric approach or cardiac-centric approach. We have to, and we should, targeting the weight in managing patients with type 2 diabetes rather than something else. In the early 2000s, we said it's just diabetes control, or we need to control the diabetes or the dysglycemia. In 2010 to 2015, it was cardiac-centric approach. We should take care of the cardiac vascular complication or the risk, I mean. Nowadays, it's weight. So we do have a lot of success story in managing patients with weight and weight reduction. We do have virtual gestational diabetes mellitus care. You can imagine like patient with diabetes, female pregnant patient with diabetes in the north or down in the south. They don't have or they don't have access for specialized and well-trained diabetologists, and they don't have like certified nutritionists as well. They don't have clinical pharmacists. They don't have even psychologists. So telemedicine or telehealth can help and can solve the problem. Also, we leverage the use of AI. We start this great program called Aina. It's using AI model for screening patients with diabetes for their diabetic retinopathy. I'm sure as diabetologists we are suffering in referring our patient for diabetes screening, diabetes retinopathy screening. So we start this program before 1 year, and we reach more than 15,000 patients so far. Amazing stuff. Just the patient go to any PHC, and he just put his head on the machine, photo will be taken, will be sent to central portal. The AI model will read the image, and ophthalmologist will approve the result. So also صحة virtual doing like administrative role, and we are trying to supervise all virtual care, including the diabetes care. We will not talk about the current healthcare challenges. My colleague, Dr. Mat'ab and Prof. Khalid, they talking about, but I will talk about implementation challenging analysis, or what are the barriers to start or to implement virtual care. We can see the virtual care is superior. It's a perfect tool to managing patients, especially in the rural area, but there are a lot of obstacles. We can see the top challenges in virtual diabetes care. We can see 77% it's technology barrier, 54% it's re-impairments, 85 physical exam limitation, 68 scheduling complexity. This is the most important slide in the implementation. The major implementation barrier by priorities. First of all, infrastructure limitation. Second, it's data security issue, and this is very, very important, and it's one of the major obstacles. Usually we get companies with great solutions, great platform, but we cannot use it and we cannot apply it to our patient because their server is outside Saudi Arabia. Financial, for sure, it's costly. It's not cheap price. It's very costly. High implementation cost, limited re-impairments policies, device issue to maintain the services. Also, it's costly. And for sure, we need training requirement. But poor internet connectivity in rural area, this is a major issue and obstacle. So just some statistic worldwide, you can see 45% it's infrastructure gap, 2.8 billion digital access, 68% provider readiness. So just 68, they are ready. The others, they are not ready. The security concern is 71% or even more for the governmental and nations to serve undeveloped country. This is really a big barrier and big challenges. Global adoption barrier, you can see infrastructure, cost, training, security, regulation, and so on. So solution and implementation strategy, infrastructure development, partnership approach. We need to do great partnership with companies and with, for sure, IT companies and training program. So finally, I will conclude my presentation with this great sentence. In the coming years, telemedicine is likely to lose its tele prefix and simply become medicine. Thank you.
Thank you, Dr. Abdullah. So our next speaker will talk about diabetes prevention and control in MENA region, targets, progress, and challenges. Dr. Khalid Nada from WHO. Dr. Nada is currently a public health officer at the WHO country office in the Kingdom of Saudi Arabia. Dr. Nada graduated from the School of Medicine, Cairo University in 1992, obtained an MSc from the London School of Hygiene and Tropical Medicine in Health Services Management 1996, and an MA in Health and Development Economics from the George Washington University 2001. Before joining WHO, Dr. Nada was program manager at the delegation of European Union to Egypt, and he was a health economist with the Dubai Health Authority. Dr. Nada has published numerous articles in peer-reviewed journals, in addition to numerous reports in the fields of health services, research, and health economics. Welcome, Dr. Khalid.
Assalamu alaikum. First of all, the presentation now is going to take you, we'll zoom out a little bit, we'll take you away from the focus on diabetes and Saudi Arabia and try to focus on the bigger picture, the global and mostly the regional situation in relation to diabetes. I think, as mentioned, we will talk about the current status very quickly and the targets. Some of the frameworks that WHO is employing in this area, and then whether we are achieving progress or not, and the challenges we face, and finally the way forward. I'm using here the data from the International Diabetes Federation, which are conservative estimates compared to those of the WHO. As you can see from the top right, the world indicators for 2024, we have around 600 million cases of diabetes. And this is expected to increase by almost 45% by the year 2050. In addition to this, we have around 635 million suffering from impaired glucose tolerance or pre-diabetics and so on. 3.4 million who have died during all of this for 2024 from diabetes-related causes. And then in 2024, for the first time, the direct expenditures related to diabetes, meaning the healthcare costs, exceeded 1 trillion for the first time in history. Now, this is showing the progression of the number of diabetes cases starting from 2000 and then up to 2024. It increased from 150 million to almost 600 million, fourfold increase in just 25 years. This curve shows our expectations about the number of diabetics in the future. So if you look here in this year, 2003, we expected that in 2025, we'll have 333 million diabetics, okay? Just 3 years later, our projection for the same year, for 2025, we increased from 333 million to 380 million, okay? Now, we know that this number is not realistic. We now know that it is 600 million. And then every single year that we made an estimate, the estimate kept, the projection for the future kept rising. And yet, every time it was rising, and yet we didn't reach the real one, which is now 600 million. And this, again, is a conservative estimate. In our region, diabetes, first of all, let me say that our region is the worst. And just a clarification that the region, WHO has a headquarters and 6 regional offices. In our region, we have all the Arab countries except Algeria. We have 3 non-Arabic speaking countries, Afghanistan, Pakistan, and Iran. The International Federation estimates include Algeria and exclude Somalia and Djibouti. So it is more or less the same, but with slight differences. in the region, in our region, the EMRO region or the East Mediterranean region, diabetes is 17.6, which is the highest in all other, compared to the other 5 regions. In 2024, there were approximately 457,000 diabetes-related deaths, and up to the age of 79. But if we reduce this to include only the working age up to the age of 60, it is even higher. It is 21.6. 1/3 of those cases are undiagnosed, so people who are suffering from diabetes and yet are not diagnosed. And these are the top 5 countries. I'll just leave you to look at them. In the top part of this table, it shows the number of people in millions. So the largest is in Pakistan, 35 million, followed by Egypt, 13 million, then Iran, 5.5, Saudi Arabia, 5.3 million, and then Algeria. If you look at the lower half of the table, we are talking about the prevalence, okay, age standardized prevalence, and you can see that still more or less the same countries, but now Pakistan, Kuwait comes second, Qatar comes third, Saudi Arabia remains in the 4th position, and then Egypt comes 5th. So we can see that our countries are suffering from a large burden, but also here we can see that the Eastern Mediterranean region, the one with the 3rd column, that only 40% of our patients receive treatment, and around 60% still are not receiving the treatment that they deserve. Now, because I'm talking now about regional or global, I'm not going to talk about specific indicators, but I'm going to tell you that the most important set of indicators to see the progress and development is the Sustainable Development Goals, and these are global indicators that all countries report on. You can see from this that they have 17 goals. Health is the goal number 3, the one in the middle. But we are talking about poverty, we are talking about hunger, education, and so on. And for the 3rd goal, which is health, we have a set of indicators. So we have, for example, a set of targets and indicators. The target, for example, 3.4 is the one that deals with non-communicable diseases. Not specifically cancer, but not specifically diabetes, but the 4 main ones. The cardiovascular, cancer, diabetes, and chronic respiratory diseases. And then we have an indicator to measure our progress, and we are assuming that countries are trying to follow up on these, all these indicators, all the 17 areas of Sustainable Development Goals. And in our case, we are supposing that we should reduce the mortality from non-communicable diseases in general, not diabetes in particular, by 1/3 by 2030. Because diabetes is such a challenge, we know that we don't have a single framework or a single set of targets or whatever. But I'm just selecting some of the ones that may be relevant to us. For example, here, the Global Diabetes Compact was one of the initiatives of WHO, where the idea was to try to achieve certain targets specifically for diabetes. And you can see these targets, and you can judge for yourself whether we've achieved them or not. In most of our countries in the region, the 22 countries of the Eastern Mediterranean region, these targets were not achieved, unfortunately. As I said, because you have a complex problem like diabetes, you can assume that every country and every region will try to have its own way of dealing with it and try to develop a framework where they can use the framework in order to improve the situation and follow up on their progress. So, and I'm just, before going through the specific frameworks, I'm just giving you an example of the resolutions. I don't expect you to remember them or even know what the content is, but there are plenty of them. And the only thing that may be of interest for those who are interested in the understanding the abbreviations and so on, the United Nations, they have a meeting every year. Just last month, we had a meeting. And there was the 4th high-level political declaration or meeting on one of the most serious issues, which is non-communicable diseases. And this was preceded by 3 over the years. But also the specialized agency in the UN system is WHO, which is dealing with health. And this entity, the WHO, is a organization that is managed by the member states. It's a member state organization. So our highest authority in the WHO are the ministers of health in the 194 members, where they meet every year around May of every year, where they come up with they come up with decisions, and the decisions are reflected in resolutions. And this one, for example, For example, this, if it starts with W, HA means the World Health Assembly, which is the meeting, the general meeting, which all countries attend and take decisions on what are the priorities in the coming year. But also for each of the 6 regional offices, we have a meeting every year again. And this is in October, as I mentioned. It starts with EM, the Eastern Mediterranean, then RC, the regional committee, which is the body of all the ministers of health of the countries in the region. For example, all the Arab countries except Algeria, as I said, and so on. So these are the kinds of resolutions that we come up with, and these guide our actions in the area of diabetes or whatever that we think is a priority in our. So for diabetes, we had 2 main frameworks. This is one of them. This was developed in 2021. And there was another framework in 2023, but focused on countries. Remember, in our region, we have half of the countries are suffering from disasters, man-made or natural disasters, and so on. And so they have specific needs that warrants having a framework to deal with such situations. So this framework, which was developed in 2021, outlines almost 30 strategic interventions across 4 major areas. Okay? So, and then there are indicators to follow up on the progress as well. The first of these 4 areas is governance. And this is, these are the main ingredients of any program. If you would like to have a program, then you need to have a policy or a strategy, you need to have an implementation plan, you need to have a budget, and so on. And so these are the basic needs of any diabetes or any other program in health, where you need to have these in place in order to have a functioning program. So we need to establish a national subcommittee for diabetes, which works under the larger committee of non-communicable diseases, an action plan, establish a program if you don't have one. Remember, this is a framework for all countries in the region, which range from the countries which have enough resources and well-established healthcare systems to have a developed system and so on, but also have countries where they have fragile healthcare systems where they may not have a program to start with. We identify or define the essential set of integrated interventions as part of a universal healthcare package of services, budget, national capacity, and which is not sometimes, but mostly in most of the health conditions, we overlook the feedback and the support of the people who are suffering from that particular condition. We all know that diabetics may suffer discrimination, and they have enough experiences that can help us in developing programs that are successful and can lead to better results. The other thing is prevention activities. I won't speak about this a lot because of our colleagues have already mentioned that, but we need to control all the factors that contribute to diabetes. As we've heard, there are risk factors that we cannot influence, for example, age or ethnicity or whatever, but there are risk factors that we can influence. Your diet, physical exercise, your body mass index, and so on. So these are the areas that you need to interfere with if you would like to reduce the incidence and prevalence of diabetes. We all know that there are a lot of relations between, for example, hypertension and diabetes, smoking and diabetes, and so on. And these are particular areas that we already have successful programs that are known to be effective and produce results. For example, the Framework Convention on Tobacco Control was the first program that was a convention that was adopted by countries globally that were members of the WHO, and the WHO is a secretariat for this convention, and it is a program that when applied, it yields results. It is useful. And one of the most effective things in that program, for example, is raising taxes on tobacco or having plain packaging of tobacco products. And both of them are areas where Saudi Arabia excelled, to the extent that Saudi Arabia is the first country in the region that have implemented plain packaging of tobacco products and is using the experience to guide other countries in our region. Management, again, management of diabetes is something that I'm not going to talk about much because we've already heard the experiences. And these are the ingredients of any diabetes control program in your country. Prevention and control will depend on these ingredients which are already present in Saudi Arabia. So I'm not going to delve more on this. Finally, you need to have a good surveillance system and you need to have good research. And as our colleague has mentioned, that research should be coming from our own context, from our own experiences, and should be reflected on us. And it will definitely, if it comes from our own experiences, will produce results that will help us achieve better performance in our diabetes control. So, and these, for example, having a diabetes registry and linking it with other registries. This is something that is important in the sense that we can understand, have a better understanding of the situation, and by having a proper surveillance, we can really follow up on our activities and then see the results and see what is working well, what is not, what needs to be improved, and so on. So we can better achieve results with a good surveillance research center. Now, if you come to progress in our region, well, I think we already know. Yeah. So as I mentioned, that there are, of course, indicators that any diabetes program would have. You would like to know whether your coverage is good or not, whether glycemic control is good or not, and so on. So we have plenty of indicators. But if we are talking about a region or globally, then I'm going to use a global set of indicators. And as I mentioned, the Sustainable Development Goals. And we have a process of reporting on the achievement of the SDGs, or the Sustainable Development Goals. And these are very generic, very general. They are not diabetes specific. For example, you can see that between 2010 and 2019, the probability of dying between the exact ages of 30 and 70 from any of the 4 main NCDs, not specifically diabetes, in our region it decreased from 27% in 2010 to 26% in 2015, and then 25% in 2019. If you recall, I mentioned earlier that we need to reduce this by 1/3. Now, this is not 1/3, this is far less. Okay? And we can see that there is a lot of discrepancy within our region because of the wide discrepancy in the situation of the different countries. For example, you can see that there was a decline of 15% or more in 3 of the countries of the region, Oman, Qatar, and Saudi Arabia. Whereas in other countries, there was not much change. There was even increases in 2 other countries, Libya and Syria. And this is the probability of dying from any cardiovascular disease, cancer, diabetes, and chronic respiratory disease between the ages of 30 and 70 in the countries of our region, the 22 countries. You can see, if you'd like to focus on Saudi Arabia, this is for the year 2010, decreased slightly by 2015, and a bit again in 2019. So for the whole region, the last bar here, again, there is decrease overall in the region, but it is very little, and it will not definitely lead us to achieve our target by 2030. Now, if I use our framework, the WHO framework for dealing with diabetes, and I said the framework consists of 4 major areas: governance, prevention, treatment, and then surveillance and research. You can see that in the area of governance, well, about 2/3 of the countries already developed multi-sectoral policies to address NCDs, which is not really an impressive achievement, but this is the situation that we're in now. When it comes to prevention, there are best buys. There are certain advice that we believe are the activities that if you take, you will achieve the better results. And there are some examples of here. And let me speak about Saudi Arabia a little bit about this, because most of these are areas where Saudi Arabia not only applied, but excelled in applying and achieving results based on that. For example, if you're talking about reducing the intake of sugar, sugar-sweetened beverages, and reduction of trans fats. Now, Saudi Arabia has applied taxes on sugar-sweetened beverages almost 10 years now. And this, after applying it, has resulted in a significant decline in the consumption of such drinks. Trans fats, Saudi Arabia, starting for almost 5 years ago, decided that we are not going to allow the use of trans fats in the processed foods. And this was achieved to the extent that Saudi Arabia received several awards on such an achievement. And this was an example that is used to promote the concept among other countries. And Saudi Arabia has a WHO collaborating center, which is stationed at the Saudi Food and Drug Authority, which uses this kind of experience that was gained in implementing this to help other countries achieve it as well. The adoption of the WHO Framework Convention on Tobacco Control, again, this was adopted by WHO, by Saudi Arabia years ago, and it was applied, increasing the taxes on cigarettes and tobacco products in general, which now taxes, for example, account for almost 73% of the price of a tobacco product in Saudi Arabia. And this, of course, led to a significant decline in consumption. In addition, of course, to the other regulations and changes in laws and so on. 5 minutes or خلاص? طيب. I'll be quick, inshallah. Plain packaging proved to be successful, and Saudi Arabia was the first country in our region to apply it. And there is another WHO collaborating center, again, at the Saudi Food and Drug Authority that spreads this kind of experience among other countries in the region that would help them. Now, promoting physical activity and healthy settings, 2 other topics. Promoting health activity, the Public Health Authority is developing guidelines and so on. There is a whole effort there. There is another WHO collaborating center, the Public Health Authority. So this is one area. The healthy settings intervention. And there is a major program called the Healthy Cities Program. This is a program that was introduced by WHO more than maybe 30 years ago. Saudi Arabia is the leading country in our region in this program. And it is a program where we don't select, but the government, through the Ministry of Health and through its interaction with the municipalities, local government, where they agree on trying to certify a particular city or even a neighborhood within a city as a healthy city. And how this works, this includes all aspects of health, including having enough space for physical exercise and activity, for example, for jogging or cycling and so on, community participation and so on. It's a very interesting program. Now, Saudi Arabia is the leading country in our region. There's almost 15 such cities. 1 university, again, the first university in our region to be a health promoting university, the Princess Noor University in Riyadh. And it is progressing. Again, the Ministry of Health has a WHO collaborating center on healthy cities and is spreading this kind of experience and knowledge to other countries in the region. And this is a unique, by the way, collaborating center. There is only 2 or 3 globally, 1 in the UK, 1 in Japan, and 1, I think, I don't remember the third country, but again, there are few of them. Progress under management, again, WHO has a number of technical resources. For example, the therapeutic patient education is relatively a new initiative that is being piloted in Lebanon and Jordan at present and should be, and it is similar to the other activities. We all know that diabetes is not a clinical condition that you treat in the hospital or the clinic and that's it. The patient needs to have health education to understand and become part of the treatment regime, part of the management of the case of the disease, and this is more structured in depth in that area. WHO package of essential non-communicable disease interventions is one of the guidelines. Again, the HEARTS package is a third one, and so on. We have plenty of these. This is a point that tells us that during humanitarian crisis, people don't only die from malaria and cholera and whatever. They die also from non-communicable diseases, complications, where, for example, patients who need renal dialysis cannot get it. Now, in our case in Saudi Arabia, for example, is supporting this in countries. For example, in Sudan, there is a program funded by the King Salman Humanitarian and Relief Center to fund renal dialysis for people in Sudan and for Sudanese refugees in Egypt. So, highlighting the importance of this in humanitarian settings, not only communicable diseases. Okay, some progress in this area. I'll just skip it for the sake of time. Now, what are the challenges? Challenges are common everywhere. The weak multi-sector approach in combating diabetes in most countries. You find the health sector is in one direction, and then the education sector is another one, and municipalities and local governance is the third direction, and so on. And in order to have successful control of diabetes, prevention and control of diabetes, you need to have a multi-sector approach. Many countries lack access to quality, safe, effective, and affordable essential medicines. Again, Saudi Arabia, this is an exceptional case. The Saudi Food and Drug Authority has reached the highest level of maturity. There is a classification of 4 levels. Saudi Arabia has reached level 4, where only few countries in the world have achieved this level. And the objective here is to tell you about that making sure that you have an effective national regulator means that you have access to medicines, diagnostics that you can trust, and you know their quality and so on. And making them available and so on is an important part of diabetes. Insufficient funding for implementation research, another area that we have a program, but we don't have a good monitoring evaluation component, or we have it, but we don't have implementation research. There are certain things that you need to do research to find. Not all things can be followed up by the monitoring evaluation system, and this is an area of weakness. Shortage of qualified workers in many countries. The fragmented healthcare systems, again, if you need to treat a patient with diabetes, you don't only need a physician, you need a physician, a nutritionist, a health educator, and so on, and a good lab, and so on. If this is not working together, then there is a problem. Another area, and this is another area where we have, at least in Saudi Arabia, have a good e-health component. This can be used for promotion, this can be used for sharing information, for following up with patients and having virtual consultations and so on. So the way forward, there are areas on behalf of WHO, which is all the areas we've talked about, we should push forward, but at the level of a country, we need to have good governance. Nothing will be achieved without having a good governance. Ensure continuity of diabetes services, especially in emergencies and so on. And how do you do this? And this is not only in fragile healthcare systems. This applies to every country. Any country may have, say, a lot of rain, then all of a sudden we have, the healthcare facilities are not accessible for flooding or whatever reason. Then this needs to be part of your preparedness plans. All countries have preparedness plans. Then you should include in your preparedness plans access to communicable and non-communicable diseases services. Strengthening prevention, early detection through the implementation of a national screening program. This should be part of your health insurance coverage, and this should be part of your primary healthcare level access. And finally, improve equitable access to medicines and technology through increased funding and ensuring that this is included in all levels of care as well. Thank you.
Please invite all speakers to the stage for a panel discussion. So we have around 10 minutes for questions. Even less than 10 minutes, maybe 2 to 3 questions. So if you have any questions, please raise your hand.
يعطيك العافية.
تفضل دكتور. Do you have mic?
Thank you very much for the 4 speakers. I enjoyed the lecture of Dr. Khalid Rubain, my old friend, or my young friend. Do you think, Dr. Khalid, that the early days although we have diagnosed diabetes and giving care to the cardiovascular, this is because not only the cardiovascular, but the players of the cardiorenal metabolic syndrome are there even without the manifestations of the cardiovascular, so it will take the patient to the mortality earlier than to do stent or to intervene with the cardiovascular. This is number one. Second one, and maybe the last, do you think that the increased prevalence of diabetes, either type 1 or type 2, because we have some hidden players for the epigenetics, as you mentioned, for the microbiota or so, but there are also many players are there, so are we dilemma in diabetes don't discover till now?
Yeah, thank you very much, Doctor. Let me go to the first question, which is, are we seeing more mortality in the old times because of cardiovascular disease than what we are seeing now? The answer is yes. I think the reason that we are more conscious on screening those diabetic patients for cardiac comorbidities and picking them up and treating them. So this is why they used to die early, but now they can live longer. The other reason, in fact, is that renal disease and other diseases, especially infections associated with low immunity, is becoming more aggressive. We are seeing more viral diseases, more aggressive viral diseases now, which can affect diabetic patients more than what used to be. But there is a very clear observation from many nations that there is a very clear shift, like the figure I have given you. The second question is, yeah, I've been working on epigenetics. You know the guy who won Nobel Prize 2 years ago about mRNA discovery. We worked on the mRNA earlier, in fact, and we think that there is an epigenetic factor, definitely. But the point is, where is it coming from? Are we talking about diet? Are we talking about environment? You know, pollution is now one of the issues that blamed for the high incidence of diabetes, especially type 2 diabetes, but also type 1 diabetes. I think I agree with you. Epigenetics has a role, but I think there is a way, it is a way ahead of us to really pick it up. But if we could really recognize it, I think this will help in reducing the incidence.
Okay, we have time for one more question.
Can I ask Dr. Abdullah? Can I ask Dr. Abdullah about the virtual?
Sure, Dr. Khalidis.
Can I ask? I noticed from the international data that there is more male than females. 3 or 4 studies, 90% males and only less than 10% females. Are we having a problem with virtual management, virtual medicine when we speak about female?
Well, maybe because we get sick more than the females. To be honest, I don't see any difference. Maybe this is just from the studies, but from our experience, no, I think females either equal adapting technology and accepting virtual care more than the females. But I think because most of the studies that I present from USA is from المحاربين القدامى. Maybe because they do have good record, selection bias maybe, and they do have good access care because they are well respected and they do have open access.
Okay, Dr. Salah.
Thank you very much. Join the talk of everybody here. And obviously لا يفتى وما لكم في المدينة. الأخ خالد أستاذنا كلنا في علم السكر وعلم الباطنة وعلم الشعر وكل العلوم هذه. I have comment on Dr. Abdullah's talk about regarding the telemedicine and the virtual care. And I think nowadays there is a great role for it. We know that the scope of telemedicine is very wide, and it depends on how we are going to use and which part of the scope we are going to use. And I think it has a role in the follow-up. We know that the patient with diabetes may have problem with the continuity of care. They may have a problem with the compliance. They may have a problem with the availability of the medications. And I think in all of these, I think combining the telemedicine together with the home care as well, and nowadays with the availability of the remote control gadget that we have that is available and it can pick many things, I think there is a great role for the telemedicine and the home care combined in providing the continuity of care to our beloved diabetic patients, especially in cities where it may be difficult to elderly people to reach to the hospitals. That is my comment.
Thank you, Prof. 100% agree. And to your point, Prof. Salah, we do have currently in Saudi Arabia more than 18 advanced diabetes centers. But unfortunately, we don't have much expert in diabetes surfing on those centers. Even, I'm not talking about only physicians, even certified nutritionists, clinical pharmacists, psychologists as well. So this is really an obstacle. And by the way, nowadays, I have some patients in my private and governmental sectors, they asking for virtual care. Can you give me my result through phone or virtually? Can I go to this application, the National Sahhati? Can I get my result to Sahhati? Can I reach you through Sahhati? And so on. And by the way, our nation are let's say, technology, or driven. Most of our people in Saudi Arabia have smartphone. They have good internet connection and so on.
Okay, thank you so much. I think we came to end of the first session. Thank you.
Thank you. أهلا وسهلا بك دكتور عبد الله، بارك في حضرتك.
Thank you, Dr. Ahmed, and big thanks to our distinguished speakers. Now we will start the recognition. Starting with Prof. Khalid Rabi'an. دكتور أحمد إسماعيلي. دكتور عبد الله الوابل. دكتور خالد ندى. By this, we will end our first session. We will have a 10-minute break. Welcome back, everyone. And now we will begin our second session titled Advances in Technology and Multi-Sector Roles in Diabetes Care. This session will be led by our moderator, Dr. Wael Al-Zahrani. Dr. Wael is a consultant endocrinologist and director of the Endocrine and Diabetes Department at Prince Sultan Military Medical City. Please join me in welcoming Dr. Wael.
Assalamu alaikum. Good morning, everyone. I'm really glad to be invited from the organizing committee for the first Congress for Diabetes. And thank you for the introduction. Our second session will be about the advance in technology and multi-sectoral role in diabetes care. We will have 4 great speakers and healthcare leaders in international and local organization. Our first topic will be presented by Dr. Ali Shehri. It will be about the obesity and type 2 diabetes, the missing link. Dr. Ali, he is a consultant and chairman of the obesity department at King Fahd Medical City, and he's also served as vice president of the Saudi Society for the study of obesity. So please joining me to welcome Dr. Ali.
Assalamu alaikum wa rahmatullah. So it's my pleasure to be here today. Thank you, Dr. Mat'ab Al-Ataibi, for the invitations. And I know we are running out of the time, so my presentation will be very concise and to the point. So as you know, obesity and diabetes is a very interactive, I would say, very linked disease together. One of the most common chronic disease in our nation is the obesity. And if you look to the growth trend of obesity and between adults and even pediatric age group in our region or in our nation, it's trending high, and the projection rate of prevalence of the obesity is expected to be around 45% by 2030 if the trend continue to be the same. So that's really a very challenging, I would say, and alarming issue that we need all to focus on. And from that point, all the initiatives in the health transformation programs under the umbrella of Vision 2030 has addressed that and looked to the importance of stopping the progression for the prevalence of the obesity. If we look about the prevalence between obesity and type 2 diabetes, so almost 90% of adults with type 2 diabetes either overweight or having obesity. That's international data. But if we look to our local data that has been conducted by some of our colleagues from the primary healthcare sectors, they found that almost we have 27% of patients with type 2 diabetes either overweight and 57% having obesity. And other data talked about 31% overweight, 46% of the type 2 diabetic patients were found to have obesity. So obesity is recognized now as a disease, and it's one of the chronic disease with a serious morbidity and increased mortality, and one of the main metabolic complications of the type 2 diabetes. So this is 2 conditions that share almost the same or similar pathophysiology mechanism. And in the past decade, I would say the management of type 2 diabetes has gone through a very dramatic shift in the management, focusing more from the glycemic control only toward more broad and more wide, I would say, view regarding the management, focusing in the cardiometabolic aspect in a very wide, I would say, view regarding the disease and the pathophysiology and the complication of the disease. So obesity is a major driver for type 2 diabetes and excess fatty acid. There is a very complex pathophysiology mechanism where it can be summarized through this diagram, where you can see that the adiposity is influencing almost hundreds of inflammatory markers and mediators that affect the pathophysiology of the disease and leading to significant, I would say, impact of that process that started with excess adipose tissue and then inflammatory and altered adipokines that led at the end to significant insulin resistance and beta cell dysfunction and failure, and at the end persistent hyperglycemia and type 2 diabetes. And that explains for you that the core of the problem here is started from the obesity and the adiposity specifically. So it's interconnected and heterogeneous disease, and both of them very interacted. So not everyone who has having obesity or BMI more than 30 have excessive adiposity. So and this is why nowadays we are trying to shift from defining the obesity based on the BMI only to more, I would say, wide spectrum regarding the diagnosis of the disease toward the complexity and the complication of the disease. And some people who is having type 2 diabetes is just having minimal adiposity, but they develop a serious metabolic complication. But although those people is still getting benefit, even if they lose weight. So the weight loss benefit has been documented regardless whether the pathophysiology of the type 2 diabetes was dominated by insulin resistant, beta cell dysfunction, or even adiposity or not. So weight loss is always helpful for those patients, whether they have high BMI or not. And we started even to see that even with patients with type 1 diabetes, where they have a significant impact on the control of their disease when they treat the obesity. So there is a vicious cycle between obesity and diabetes, where obesity will start this cycle and it end up by glucotoxicity and some developing of diabetes, and then patient will undergo treatment for diabetes with some medication that contributed to weight gain and making the comorbidity worsening. So to break that cycle, or to have the golden intervention here, is just to focus on the treatment in a parallel way, glycemic and weight control at the same time. So there is a two different approach nowadays we see in the diabetes management, which is either glycemic targets or weight targets. So, and I think both of them should go parallel and on the same direction. So here is the benefit of the weight loss across the disease spectrum. And probably what you can see at the top of this diagram is the initial process that happened in the body, which is start years before the diagnosis of type 2 diabetes, which is the hyperglycemia, beta cell impairment of the beta cell function, insulin resistant, adiposity, and then development of the disease, and starting the vicious cycle of complication and so on till the progression of the even micro and macrovascular complications. So early intervention here is a very crucial to prevent this complex cycle. And here we can see how the weight loss can impact very significant on the development and progression of type 2 diabetes. And as mentioned by Dr. Mit'ab in his previous presentation, that even a modest weight loss of 5% could play a major role in prevention of type 2 diabetes. And once this percent increase, we might achieve even disease resolution if we have 15% and more total body weight loss, which is nowadays not something challenging with the current, I would say, development of the treatment for obesity management that we will go through very quick. So here is the last update from the ADA 2025 that, again, emphasizing to focus both toward glycemic and toward weight management or weight approach regarding patients with type 2 diabetes. So it's very important that you include the measurement and anthropometric measurement for obesity for each patient with type 2 diabetes, and monitor that regularly, screen for complication, and again focus on both glycemic and weight control. And when you choose medication for type 2 diabetes, it's very important to consider that. So the intervention started with lifestyle intervention, which has been proven some benefits in the prevention mainly, and even in the management of the disease. but probably the sustainability of this disease is a kind of challenge. And here there is a multiple data that support the effectiveness of the lifestyle intervention. One of the most famous is direct and look-ahead trials, which has looked to the impact of 5 to 10% weight loss and the impact of that on remission or even prevention of type 2 diabetes progression. The challenge that we face with the lifestyle is the sustainability. From that point, availability of the current pharmacotherapy associated with weight loss is a very promising, and we have over the past decade a significant, I would say, development in the treatment for obesity through the GLP revolution that we have seen in the last few years, and the effect of this GLP in the treatment of the weight and in the treatment of type 2 diabetes. And here is the available pharmacological options for weight management. And we are lucky in our nation that we are almost quite similar to the European countries, where we have almost 6 agents or 5 agents for the treatment of obesity. And in US, there is another 2 more agents, which is the phentermine component, sympathomimetic. But if we come to our nation, the orlistat, which is the first anti-obesity medication that approved by Saudi FDA, not widely used, and liraglutide was the second, which is the short-acting GLP-1, followed by approval of Contrave, which is a combination of naltrexone and bupropion, and followed by tirzepatide, Mounjaro, and lately we have the semaglutide 2.4 or Wegovy. So there is many conventional glucose-lowering agents that result in weight gain, and this is a very important when you choose the treatment for patients with type 2 diabetes. Sulfonylurea and other old generation of the anti-diabetes medication, insulin, is all contributed to weight gain. So it's very important when you choose the option to choose the therapy that's either weight neutral or having weight loss potential. So the recommendation is, when choosing this medication, is just go toward the weight neutral or weight loss medication that could affect and target both objective, which is either the weight or glycemic control. Metabolic surgery, as mentioned by Professor Bayan, will play a significant role in the remission of the disease, and we have seen that especially with the wide, I would say, availability of the bariatric surgery in our nation. And we can see that those patient who has either sleeve gastrectomy or Roux-en-Y gastric bypass, they have almost 70% chance of type 2 diabetes remission. A major shift in the guideline has been done a couple of years ago, which is lowering the BMI threshold for patients who is going to bariatric surgery, and starting, if they have type 2 diabetes, from BMI of 30, which is a major shift that haven't been done almost in like 3 or 4 decades. So now the indication for bariatric surgery started from BMI 30 or more if the patient has suboptimal control for type 2 diabetes. And here is the benefit of the bariatric surgery that definitely outweigh the risk, far away outweigh the risk, and the risk of death from the procedure is almost quite similar to what we can have with simple laparoscopic surgery like acute cholecystectomy, laparoscopic cholecystectomy or laparoscopic appendectomy. So in here some data that summarize the benefit and the remission of the disease regarding bariatric surgery. And we can see that the Roux-en-Y gastric bypass is producing the most prominent and sustainable effect if we came regarding the glycemic control and remission of the disease. So the recommendation, again, as we mentioned earlier, bariatric surgery is one of the most, I would say, effective tool regarding the remission of the disease if we choose the right candidate for that. And best people who will get benefit is patient with BMI more than 35 or BMI more than 30 with difficult to control their disease. So what's the emerging concept or the future direction? So definitely the next generation incretin, or what's called the third generation of the anti-obesity medication. We're having the double and triple agonist is coming in the pipeline, amylin co-agonist is also one of the promising future interventions. Oral molecule also is playing promising role in the treatment of both glycemia and weight. Inflammation-directed therapy also is something that's emerging in the pipeline, in addition to the microbiome direction, which has been highlighted by Dr. Rabi'an in his presentation. And again, the phenotyping approach of the chronic disease is very promising future direction for the treatment of such disease. So in just trying to summarize what we are saying here is very important to have a checklist that focus on both A1C plus weight, look beyond the BMI, don't focus only on numbers, and prioritize the treatment toward the weight loss medication rather than weight gain medication for patients with type 2 diabetes. Interfere early, consider the GLP and bariatric surgery if the patient need, plan for long-term management or plan for long-term maintenance. And remember, this is an individualized approach disease. There is no one size that could fit all. So in the home message, obesity is a core role for multiple medical problem, and definitely type 2 diabetes is one of those. There is a strong and consistent evidence that obesity management can delay the progression of the pre-diabetes and even remission of some patients with type 2 diabetes. Glycemic improvement and diabetes remission are realistic goal, and people should be empowered to seek that goal when they are ready to do. So before I conclude, just to have very quick view about national initiative for obesity prevention in a couple of slides in Saudi Arabia. This is done. I just adopted some of these slides from our colleague in the CDC, where they have a very promising initiatives regarding trying to help with the prevention of the obesity over the nation. And if we look to the prevalence that I have already illustrated that in the first slides, from that they built their strategy, or what we call the obesity control and prevention strategy 2030, that has 3 levels: primary, secondary, and tertiary. And the primary focus on the health and a healthy environment. Secondary focus more on early detection and risk stratification, and the tertiary is clinical management for patients who are already struggling with their disease. And there is multiple, I would say, society action, or multiple, I would say, partner, including Ministry of Health, Ministry of Education, Saudi FDA, and many other stakeholders that contributed to that. This is a very promising initiatives, and we should all work together to help them to reach that. I would encourage every one of you to go to the CDC website and trying to download this initiative, which could help most of you to elaborate more regarding the prevention of the obesity as a key driver for the development of type 2 diabetes. So by that, I conclude my presentation. Thank you very much for your time, and back to the chairman.
Thank you, Dr. Ali, for the simplification of linking between obesity and type 2 diabetes, and also for the update about the management and prevention. Our next topic will be about the Global Diabetes Atlas, what the numbers mean for the Middle East. It will be presented by Dr. Misbah. He is a consultant in internal medicine and endocrinology with years of leadership in regional and international organization. He served now as chair-elect of the IDF MENA. He is also the former president of the Diabetes in Asia Study Group and founder of the Major Diabetes Association in Upper Egypt. Dr. Saad.
بسم الله الرحمن الرحيم. في البداية بتوجه بالشكر الجزيل للأخ العزيز الدكتور متعب على الدعوة الكريمة، والدكتور الرزاز. الحقيقة يعني جهد مشكور، و it is my honor and my pleasure to represent the IDF International Diabetes Federation in this context and this prestigious conference. And actually, together we are stronger. This is the symbol of the IDF, and for this symbol, we are here today. My talk will have the other face of the coin. In the first session, we have the illuminating part of the picture regarding the Saudi Arabia and the higher income countries. Now, we will go, what about the MENA region? MENA region is Middle East and North Africa region of the IDF, one of the seven regions in the IDF. It includes about 23 countries, starting from Afghanistan to Morocco, including all the North Africa, the Middle East, Pakistan, Afghanistan, Iran, and so it is a very vast area. So, what are the numbers? This Dr. Khalid elegantly show about the numbers from the IDF Atlas, and I am proud that the IDF Atlas is our all reference in the epidemiology, and we see that the numbers are horrible and even going beyond the expectation, as Dr. Khalid said. And for the MENA region, this is the key statistics and the trends of the MENA region. MENA region have very high prevalence of diabetes, and the number of people with diabetes in the MENA region now is projected from from 83 to be doubled in 2050, and we have undiagnosed cases, and also we have substantial portion of the intermediate hyperglycemia, what is called prediabetes, and the IDF and WHO called it intermediate hyperglycemia. This is just in the nomenclature of the term, but the same is there. Either intermediate hyperglycemia or prediabetes, the same category will go without suspicion of being hazardous for the quality of life of the patient. And in MENA region, we have many challenges, because you see here, this is the 84%, 84 million now. It will increase to about 1/6, being the most challenging area in the seven regions of the IDF, and also the prevalence, as you see, is hazardous and may be reaching to more than 22. This is the only variation in the methodology, and also we have this prevalence in many countries: Pakistan, Kuwait, Qatar, Saudi Arabia, Egypt, Bahrain. These are the tops, and they will continue to be the tops even in 2050, as you see. So the matter is more important, and if you see the prevalence to be categorized, you will see that Pakistan is the first and Yemen is the last, and in between we have a very huge amount of populations at risk, because this area, the MENA region, is densely populated with frustrating health system, as we shall see. So these are the MENA region, as you see, with the prevalence. And we have also the undiagnosed diabetes to be more than 37%, and the impaired glucose tolerance with all its sequences also have age and standardized prevalence of more than 11%, and hyperglycemia with pregnancy also is very hazardous in the MENA region, being more than 19.4. So this, if we coupled it with the demographic characteristics of the MENA region, we will, in the MENA region, we have 6 high-income countries, mainly the Gulf states, and 11 middle-income countries, and the low-income countries, 4. We have 480 million adult population, 85 people with diabetes, and more than 800,000 deaths per year, and many of the people are living in areas of conflicts, and 16.5 million short of insulin. This is the characteristics of the MENA region. And this is a big challenging area, not only for the IDF, but for the WHO, for all who are working for people with diabetes or non-communicable disease. The health expenditure is minimal, as you see, and this is because of the economic burden. And we see that diabetes-related health expenditure in MENA is not compared to those in the other areas. So the dilemma of diabetes in MENA, in summary, we have top 5 countries now in the prevalence, and they will continue. We have 48 million adult population with diabetes. More are in the low and the middle incomes. And if we compare this with the fragile health systems in most of the MENA region, don't look for the lucky Gulf states, especially Saudi Arabia, Qatar, but look for the others who have even shortage in primary health care centers, as we will see. So 1 in 6 adults in MENA region has diabetes. Number will go fast, and the region has the highest diabetes prevalence and lowest diabetes expenditure. And if we look to the health system and the delivery of care in MENA region, you will see how the challenges are going up. Because in the high-income countries that having about 60 million from the 500 million population in the region, will have this, as we see in Saudi Arabia, a very good health system, very structured care, and there is no problem in the delivery of the care. And this is the best example of the standardized care. But if you look for the middle income countries, you have about 85 million from those 100 million, with some midway of the health system between the highly standardized and the high-income countries and the low one in the low-income countries. And you have it, the delivery of care mixed between the private and the governmental and the infrastructure are not so good, but not so bad. And this is only a fraction, but the dilemma is here. Low middle income countries, more than 360 million from the 500 million are suffering from the patchy delivery of care, from very weak infrastructure, from no chain between the primary, secondary, and tertiary care, no multidiscipline, and only primary care centers, and depending on the international aids in the most. So this is the picture. The area with dense population of diabetes and the non-communicable disease and the highest rates of this needs more and more and more work. And this is not the responsibility of one agent, but it is a multi-sectorial responsibility, including the WHO, the IDF, the government, the stakeholders, the NGOs, and we are here because of this. Another challenging, adding to this the region, is the disasters, either man-made or natural-made. And all of you know that in all the MENA region, we have about 48 million people with diabetes suffering from disasters, either by the conflicts or flooding or the natural quakes. So this will lead us to call of action. What is the call of action? For the IDF, it starting from the member associations. We have about 400 member associations in the IDF. They contain the base of the IDF. So must have the risk assessment and planning, try to see the roots of accessibility to treatment, patient protection of the risk of complications, and try to improve the infrastructures by asking the local health authorities and advocate for their patient. So this is conducting collaboratively by the MENA Region Council that include all the presidents of the associations, and MENA Region Council try to contact the other agency like UN, WHO, and the other international aid agencies, and then coming on the top of the pyramid, the IDF central office that have many communications with these international bodies. So, instead of making WHO and MOH only working together, because WHO, as Dr. Khalid knows, include all the ministers of health, and this is the executive arm of the health authority in any region. And IDF was just away. Now, no, IDF is in great collaboration with the WHO, with the MOH. We give all the member associations that you must cooperate and collaborate with the local authorities of health. And Minister of Health is on the top. So any association in IDF, we are requesting them to contact the local health authority and cooperate with it. because this is the way to increase the effectiveness of the care and guarantee that the minimal diabetes care can be offered. So we have many. This is in the health in the WHO office in Cairo. We have many collaborations. We have many sessions that we are needing WHO to go with us, needing the Ministry of Health to go with us. We're needing every every agent, every society can give, because the problem is more and the challenges are increased. So this integrative approach to diabetes care must come starting from the primary health care centers and going to the secondary, tertiary, and lastly, the IDF has given a recommendation in 2025 for the 2 modules of care, the basal care and the optimum care. Optimum care, when we have the opportunities, we have the fund, we have the infrastructures, as in high-income countries, and the basal care in the situations with low socioeconomics. But the objectives and the targets of the both modules are the same. Nobody with diabetes must be left without care. But the tools are different. You can use here the conventional agents like sulfonylurea or especially new generations, metformin and conventional insulin. We can use here GLP-1 and others. And even WHO has a list for the essential medicines. I think this list enough for the basal module and can serve better. So my conclusions, Mr. Chairman, that access affected by economic disparities, healthcare infrastructure limitation, and regional instability, especially MENA, we have dense population, we have fragile health system in many of the countries, and having challenges of the disasters, either man or natural made, and also integrating diabetes care with the starting from the primary health care system is vital. Training the populations, training the providers, and collaboration with every association, with every agent can give more and more and more for the care. And thank you very much.
Thank you, Dr. Misbah, for the nice presentation. And clearly that you mentioned the high prevalence of diabetes and should not be only the role of governmental hospitals. So our next topic will be about the role of the private hospitals in diabetes care. Dr. Prof. Salah Al-Faqih, he will talk about this. He is the Chief Medical Officer of Dalla Hospital, and also serves as assistant professor and practicing urologist at King Khalid University Hospital. Please join me to welcome Prof. Salah.
Thank you very much, dear colleagues, for inviting me to talk about the role of the private hospitals. And this is an honor for me not to represent only Dalla Hospital, but I use Dalla Hospital and Dalla Healthcare as an example, and I will show this example in our talk. I'm not going to limit myself to the practice in the hospital, but also in the participation in the healthcare in the health sector transformation strategy and what is happening in the population health programs and all of this. And I think we have a role as physicians, we have a role, whether we are government or private hospitals, to participate into this transformation. I enjoyed very much the speeches of our colleagues in the morning and now. And the idea of having a diabetic center in Della Hospital actually has come to me as an advice from Dr. Khalid al-Rabi'an, which I am very honored I have taught him in the medical school. فتعلمه الرماية كل يوم فلما استد ساعده رماني. He gave us the advice back in 2002, 2003. He said, why don't you establish a diabetic center? And we took this advice and we grew with the diabetic center. The other thing is that diabetes is part of our life. I'm still practicing urologist in spite of all my administrative responsibilities, but I think a medical administrator can do his job better if he practices medicine, because he know what practice is about, and he know what the patients are thinking and how they are dealing with their disease and their problems and all this, and he will be more capable of carrying out the medical administrative part of his job if he is still practicing and live with the patients. In fact, when I am from the old generation. I've been serving the healthcare sector in the kingdom since 1974. And that will equal to more than 50 years. Still practicing, alhamdulillah. Now, I stress on the history taking, and I never miss in my history taking to ask the patient about whether he has diabetes, hypertension, all this. So diabetes is one of the essential questions that we ask. And I give you a little bit of a joke. One time I asked one patient who know me very well, and I know him very well. I said, Mr. So-and-so, do you have diabetes? That is, عندك سكر؟ قال لي الله يهديك أبو عبد الرحمن. أنا ولدي عبد الرحمن. الله يهديك أبو عبد الرحمن. كل هالحالات بوجهي وتقول لي عندك سكر؟ أكيد عندي سكر. فanyway فالسكر داخل في الحقيقة في شغلنا كله. ويعني many people are يعني go around, they are undiagnosed and they don't know whether they have diabetes or not. Now, the theme of the presentation, I will use our experience in Della Hospital as an example. Establishment of Della Hospital Diabetic Center, how we establish it, why we established the center, evolution of Della Hospital Diabetic Center and services provided, support for education and research, contribution for our contribution to healthcare sector transformation programs, contribution to value-based healthcare, and we are one of the few hospitals in the country who have been accredited with the value-based healthcare, and we know that population health management is part of the value-based healthcare. Innovation in diabetes management, and we talked today about the telemedicine and the telemonitoring and all the AI into this. Now, in Della Diabetic Center, I'm not going to take a long time to this because many of the things has been discussed. Della Diabetic Center was established back in 2003. It is run by highly qualified, specialized, and well-trained personnel. I will say personnel because it's not only the doctors. It is the doctors, it is the other caregivers that are whatever their functions are. To provide comprehensive clinical services under one roof. As we have seen in the morning, that diabetic patients has so many problems, and I think we must be capable of providing all the services that they may need. And the center has expanded because we feel that this is a service to the community. We know the burden of diabetes, so this is part of our service to the community, and the center is supported by all other medical departments in the hospital, whether it is ophthalmology, dental, vascular, nephrology, whatever it is, the lab and the x-ray and all this are there. Now, I don't think the burden, one of the reasons why we established the center, because we know that the burden, and I don't need to elaborate into that. And this is from the International Diabetic Federation, and we have listened just now about the very elegant speech. And then not only in the adults, but also in the pediatrics. We started in the hospital with one pediatric endocrinologist, and now we have 3 or 4 very eminent pediatric endocrinologists because the load is more than what we expected. Diabetes is at the core of the MOH and the CHI population health management program, and that's why one of the reasons, because this is a national interest, and the CHI population health management program is one of the programs of the health sector transformation programs. What we provide comprehensive services: adult endocrine, OBD consultation clinics, pediatric endocrine, well-equipped vital measurement room, because you know that it is not a matter of taking the weight or the BMI or the blood pressure, but there are many other tools that needs to be taken. Food care clinic, which is in kind of fundus camera in the center itself, insulin pump clinics, point of care system. We know that the point of care is when they do the glucose check and whether it is in the ER, whether it is in the level, or this, because this is one of the important now, the accreditation in the Joint Commission, in the SBAHIA, and in the CAB, they concentrate on the point of care testing. It is called POCT because it is very important to ensure the quality and the validity of the results, and ensure the training of the people who use the POCT so that they can produce accurate results. Now, the center is supported by all the needed, the ophthalmology department, dental, vascular surgery, advanced cardiac department, the CAB accredited laboratory, advanced radiology, ER. We have the licensed obesity center, and we have the licensed telemedicine, and we are very lucky actually in our country because there are regulations which govern this. We talked this morning about the privacy and all this, and I think you cannot establish a telemedicine without adhering to the rules and regulations, and part of it is the security. And our colleague mentioned this morning, Abdullah Wabil mentioned about that the servers must be in the country and not outside the country to be able to be licensed. Now, has expanded over the years, and the biggest expansion came in October 2020, where we have enlarged the number and the quality of the services that we provide. And we can see, I didn't want to give you all the years, but you can see the difference in the growth in the people attending the center between 10,000 something until 84,000. You see, this is a huge number, a huge jump in the numbers that can see. So we must be up to the expectations of our patients to provide them with the excellent and the optimal care that they need. Now, as I mentioned, that the vital signs room is not only for blood pressure or the simple gadgets, but you have to have the ability to read many measurements that are essential. Food care clinic is an integral part of in any diabetic center because it gives education, it gives a preventive education, and also as well as it gives treatment capabilities. And that is the fully equipped and staffed diabetic food care clinic, which works as long as the clinics are working, the patients have access to these. Food clinic care is supported by vascular surgery and advanced vascular laboratory, because many of the tests now, vascular tests that are done nowadays, are non-invasive. Many years ago, we used to have the angiography and all this, but nowadays are non-invasive. That's why we have an advanced and non-invasive vascular laboratory for that. And in-house, in the clinic, we have the center equipped with fundus camera to screen for diabetic retinopathy. And as we speak now, we are talking about buying the one which is connected to the AI, so that will help the doctors to interpret the results. Insulin pump is an essential part of this, and I don't want to elaborate into that. Clinical This is, again, this is an integral part of this. And they are, by the way, our endocrinology, the diabetes and the obesity are all in one place because there is a big relation between them. Diabetic education is very important. Education is essential element in diabetic management. We have 3 diabetic educators: individual patient education, group education, educational courses, utilization of variety of educational materials, and Delhi Hospital is accredited so that we can get CMEs for whatever we do for that. Now we encourage research into this. We have association with the medical school, and also we have many publications. These are just examples of the publications which came out from the center. So we encourage our doctors to publish. In fact, whoever publish, he can go on a study leave, which is more than what he got in the contract. Now, contribution to the World Diabetes Day, obviously this is to the public, and all of us, we do that. The public awareness is very important. And 2 weeks ago, we had Delhi Hospital Diabetes and Obesity Conference, which many of our colleagues has participated into that. That is exactly 2 weeks ago. Now, Delhi Hospital Healthcare is an integral part of the Vision 2030 and health sector transformation strategy. So we must contribute to that. We are not in isolation. We must contribute, and our contribution must be strong and must be seen as well. We are accredited by the ICHOM, what is the International Consortium for Healthcare Outcome Measurements, which is an essential part of the value-based healthcare. We know that the equation of the value-based healthcare, the V, that is the value, equals the brooms over the cost. So we are one of the first hospitals that is accredited. And again, we are aligned with the healthcare sector transformation program, Vision 23, improving health through population health management. We're heavily involved into the population, and we have two programs for that. One of them is the diabetes, and then one is the cancer breast screening. I will concentrate now on the diabetes. And if we look into this, you will see that the population health program and رواد يعني أثر what is this? And so this is the journey of the CHI. And here we have participated in our population health program into ADA, Award Population Health Management, when we have chosen the diabetes. Many parameters are taken: the HbA1c, the age of the patients, the BMIs, the hyperlipidemia, dyslipidemia, and many other factors, the blood pressure, and all of this are taken into the data which we have submitted. And alhamdulillah, we have won 2 awards for that. One from the Ministry of Health, that is the ADA, and the other one, رواد الأثر الوقائي in 2025 from the CHI. And we are very proud that we are part of the whole system of the healthcare transformation in the country. Now, part of our innovation is the remote control, the AI and all this, and recently we have introduced one of the digital innovations we introduced is the My Way Diabetes, and this is a software which has, I don't want to go into the details of this, but use the AI and use the follow-up and the data and all this, and that will be, it is very famous in UK, especially in Scotland, in the National Health Service there, and we have adapted this only recently. My Way Diabetes, it is AI-powered diabetes management application designed for both healthcare providers and patients, support decision-making, and improve quality of care for diabetes. Over 100 certified educational videos. So it covers many aspects of diabetes for the patient as well as for the providers of care for those patients. Now, this is a very broad overview of how should we contribute, or how we must contribute to the whole system, rather than we are treating a sector of patients that is limited to the hospital. No, our responsibility is more, so the role of the private sector is more than what we get them. Now, in addition to what I mentioned, the collaboration of the our primary health care clinics, as well as the telemedicine and the home care, as I mentioned in the morning, are essential to complete the circle. Thank you very much.
Thank you, Prof. Salah, for sharing the experience of the private sector in diabetes care, not only as giving the service for the patient, but also as research and using the technology AI for giving the care for the patients. Unfortunately, our last topic has been cancelled because our speaker, he couldn't make it today. But the good news is that we will have more time for the question and discussion panel. So I would like to ask our speakers to join us, Dr. Ali, Dr. Misbah, and Prof. Salah. Dr. Arzaz also. Okay, I think Dr. Ali has an issue and he left.
ممتاز والله.
Okay.
يديك الصحة.
Let's start with the questions. Any question for our speakers or comments? Yeah.
First of all, thank you very much for a very good audience at the time of the lunch. But I think, alhamdulillah, there is no hypoglycemia by that time. So I listened to Dr. Musbah very carefully. On many occasions, that is the high income and the low income. I know that the high income and the low income are extremely important, but I think it is not only the high income or the low income. It is the will of the people who are making the decisions. It is the will of the governance. See, I have witnessed the development of the healthcare sector in our country since I started in 1974. So that more than 50 years. And I think the Kingdom of Saudi Arabia has gone far away more than any other similar. And I think the COVID, our management of the COVID is a very good testimony for that. The best country in the world in dealing with the COVID pandemic is the Kingdom of Saudi Arabia. So, and I think there are many other things that in the healthcare sector, in the healthcare development, I think in many years ago, not now, now even the things are better. Many years ago, I read a book that is by an English author. He said that when somebody talks about healthcare, there is no other country in the world that can be compared in the spectrum of the healthcare provided, taking in consideration the size of the country, like the Kingdom of Saudi Arabia. And I think what is happening in the last 10 years since the vision started is something extraordinary. And I challenge every country in the world, whoever they are, to produce something which is like what is happening. And I'm speaking not only from theory, I'm speaking from actual daily work. I've been practicing this when we talk about the value-based health care on the primary or the population health management or what development of the telemedicine or the value or the home care and all this. And I think we are, in the country is having leaps in the front, not only steps, but there are leaps in the front. It is not a coincidence that many of the hospitals in the kingdom are one of the best in the world. You see, this is not a coincidence. Now, it is not a coincidence that medications go to the people in their houses free of charge. You see, it is not coincidence that vaccination go to the people in their houses free of charge. Now, it is not a matter whether it is high income or not. No, it is a matter of a system which is working.
Okay. Thank you very much, Professor Salah. But all of us know that there are main points. I partially agree. People can make difference, but when the environment aiding these peoples. Now we have what is called the social determinant of health. Objectives. That the security of the food, security of the housing, the psychological support, the insurance, how the patient can get the medicine, how can get the care, who are caring for this patient. So when this environment is going well, okay, there is no excuse for the people to go far. But when the people have no electricity, have no food, have no security, have no care, who can take these people to the desirable environment? And this was behind the recommendations of the IDF 2025 to have 2 modules of care, optimum care and basal care. There is no excuse for the people who have all the facilities to do more and more and more. But when they are harvested from the essentials of life, I think whatever the capacity of the peoples, they can be reduced minimally change. I am not underestimating or underscore the willingness of the people to work. We are here for this. We are working in the IDF, in WHO, and all NGOs for this. But please, look to the facilities. Look to the infrastructures. Look to see what you have and what you can do. I agree partially, Professor Salah. And I congratulate the Kingdom of Saudi Arabia for this. But we must go to the reality. More of the guidelines cannot be implemented because it lacks the reality of implementation. So when you have less population, more infrastructures, and all the facilities, you have no excuse to go far beyond the objectives.
We might have an argument here. So with the, do you have a question, Dr. Abdurrahman? Okay, you want to ask your question first?
Thank you, Dr. Salah, for the overview of the integrated diabetes center set up at the health system. Have you been able to measure outcomes in general in relation to the integrated system? For example, number of prevented diabetic feet or average A1C reduction as part of this comprehensive service that you are providing?
Yes, we have. In fact, the population health program, our participation with the ministry and the CHI regarding the population health program, it is all data. I didn't want to bring data, but it is all about data, about the HbA1c, about the blood pressure, about the ages, about the dyslipidemia. All these are indicators, and that's why when we took the matter seriously, and we have a group of people to follow this. We have an excellent result with this. Now I don't want to bother you with this. Otherwise, I could have put some slides showing you the thing. But yes, we do, and we measure the outcomes of this. Yes.
Want to give a comment, Dr. Azaz?
Okay, so just a quick comment about the two discussion. First, start with Dr. Misbah. I partially disagree, sorry, with what you said about, the facilities that we have in Saudi and the services. In Public Health Authority, we invest heavily on prevention programs. We have numerous number of initiatives focusing on improving lifestyle, physical activity, diabetes, hypertension. And we do have the facilities, and we work closely with different collaboration like ministries, Ministry of Health, Ministry of Defense, Ministry of National Guard, الضمان الصحي. We work with a lot of institutions to improve overall health. We do have facilities, we do have services. And عندنا كان معنا الزميل من الصحة الرقمية. So sorry, but I partially disagree.
What you are disagreeing in my speech.
The services.
You said the first word of you now, we invest.
We invest.
What you will invest? What we have talking about is the WHO, and Khalid is here, and we said that the problem in all the programs are the fund.
Yes.
I don't underestimate the role of the population, and we are here for this, but we must also have the tools. If you don't have the tools, how can you go? You will go, but at a minimal base, So this is very good.
That's the hope with the new generation.
Even if you are investing in training of the population, you need the fund. Even if you are invest in infrastructure, you need the fund. Even now we are talking about the telemedicine and we want the server to be national, we need a fund. Everything need a fund. This is not a matter of money. We are not talking about the money as a money, but as a tool. And we are also talking about the brain of the population and the enthusiasm of the population. So we are dealing with these tools to have only limiting the disasters. If you have the disasters or have your economy collapse, what can you do? What can you do? Can you ensure all the population to have the essential medicines they want?
I agree, but we always hope for we always try to be positive and
no disagreement.
Yeah.
No.
Yeah.
I don't underestimate what is going here. This is Frank. This is Frank saying.
Dr. Matabi has
I don't underestimate, but I'm here to give the clue for the other areas. And this is a model. Here, the health system is a model. We are all wanting this model to be applied for all populations, because no diabetic patient must be left without care. So I appreciate what is going here in Saudi Arabia, and I want it to be transmitted to the all. But how this will become, this is a challenge.
Dr. Misbah, let's hear from
thank you all. It's interesting to see the debate, which is a scientific discussion. Prof. Salah, my question about the role of a private hospital in the training. In the training, for example, for diabetes, for CME hours, for education, for others. Is there any rule for training for a private hospital in the training?
Yes,
resident fellowship.
In fact, if one of the slides show this very clearly, because training and education goes into the patient, goes into the people who are working, goes into the workshop, goes into the symposia that we do, goes into advocating as I mentioned, the research, and we encourage the research and all this. So there are many venues that can be used, and also we are accredited by the Saudi Commission for doing workshops and symposia that we can get CMEs into this, and that will encourage people to come and attend as well.
Yes, this is a very good.
I have it just happened that 2 weeks ago I am a panelist on in the global health, and talking about the health sector transformation program. And I think if we apply the objectives of the healthcare transformation program on diabetes, all of them will apply. The first one is access to care. Now, diabetes must have a good access to care. The other is that the quality. You must provide the service with quality. The third one is that insist on the prevention rather than the treatment. You prevent the complications and the readmissions and all this.
Yes.
You reduce the cost, you see, and by reducing the cost in diabetes, it is not direct. By reducing the admission to the hospital, by reducing the complications, and all this, you see, you are reducing the cost. By having healthy people, you are making a vibrant, what is written exactly in there, it is vibrant society. So if you have a healthy people, healthy lives, healthy people,
Sure.
vibrant society. So all of this can be, you have actually the diabetes as a very good example of how you apply this. And that's why we have chosen, in our hospital, we have chosen the population health management program, and we work on it very hard to learn a lot about this. And in fact, practicing it is far totally different from hearing about it.
Yes.
Because when you practice it, you see the benefits immediately in front of your eyes. By practicing it, the people become acquainted with what is not becoming a theoretical, you see, like what we did with the value-based healthcare as well. The other one which we have taken is the cancer breast, which has nothing to do with the subject.
To elaborate more on that, we have the 3 to 4 plan in Saudi in the Public Health Authority. We focus on reducing the standard mortality rate, the SMR, the hypertension, diabetes, and also the smoking, the tobacco use. In this initiative particularly, it's a national initiative. We work with different ministries, we work with clusters, we work with Counselor University Affair, private also hospital, with Dalla, with Al Habib, and we do have different indicators to calculate those data and to get the data from those hospitals and to see how we can prevent the disease before it's happening. As in the previous session, Dr. Ayman mentioned that the SMR, until 2022, the SMR in Saudi Arabia, it's 510 per every 100,000 population, and we are aiming by 2030 to have it to be 324 for every 100,000 population. And alhamdulillah, we are reaching to that number, and with the help of different ministries, with hospitals, the private and the public hospital, and with the services that we have, the training programs we have, guidelines. We just published a guideline last week about the prevention of diabetes guideline. Also, we work with Ministry of Education very closely with programs for type 1 diabetes for kids in schools. So we invest very heavily on those services and those programs to try to prevent the disease before it's happening in Saudi. As I mentioned, the 3 to 4, we are aiming by 2030 to have 90-90-90, which means 90% of people already diagnosed, 90% of people under treatment, 90% of people, they are aware of their condition by 2030, inshallah. And we can't reach that number or that, huge goal without helping with different institutions and cooperation with different ministries.
Thank you, Dr. I think we are running out of time. I'm not sure if we have any more questions. Let's have the last question. Yeah.
Assalamu alaikum. My question about the prevalence mentioned for MENA prevalence of diabetic, it's including Pakistan and Yemen. Pakistan is the highest country, 26%, while Yemen, 4%. Both countries is not that rich, both near to the economic. What do we think about this variation or this big variation between Pakistan and I think there is Pakistani basmati rice. This is common in Pakistan. In Yemen, there is another factor, social factor, cat, widespread use of cat. Is this a problem, or this is some view to see about how is the difference between countries and how to manage this? In Saudi Arabia, I have practiced here 10 years. 90% of the treatment of diabetic, I think, to depend on diet, nutrition. Here, no mention this. Most of my patients coming to me, I asked them, what about nutrition? They said, no, rice I cannot take out. rice and camel, dates. No one mentioned it to them. Some of the patient 10 years treated in many big hospitals. No one mentioned to them anything. Only treatment, empagliflozin, new drugs, many diabetic food like this. But the nutrition, the basic problem in diabetic, it is not a medical problem. It is a social problem. It is a nutritional problem. It is a habit problem. This is the social problem not treated by medical. Now we are treating in hospitals. This has to be, if there is centers for diabetic, 90%, but this is basic in medicine. Diabetic have to be treated as nutrition problem. This can benefit the patient, especially in early stage, no complication. In pre-diabetic stage, how to check this? No one speak about this in all the countries. I think, even here in the conference, no special rules for nutrition, for diet, to emphasize this in the society. So this is the big problem here. Not the deficiency of drugs or deficiency of doctors or consultant or centers treating diabetic food or something. No, the problem is the
I
basic.
think the question for Dr.
A very short question, please.
Very short answer for
Hey,
this.
we cannot follow all these comments. But regarding the difference between Yemen and Pakistan, there are two items must be addressed. The first, what we are called social determinant of health, and we are addressing this social determinant of health for the variable cultures and the food habits between the two. And the other will be the density of the population in Pakistan and what is the burden on the security of food and security of care and also the methodology. This is just numbers, and we are here to explain what are the numbers means, you know. So the matter can be collectively, that these are indicators. The prevalence in a society is alarming to go for more work for prevention. And one of the prevention is education, the nutrition, and is not only to see the health problem when come. And I think one of the lectures today, Dr. in the guidelines talk about the primordial. Primordial means improving the environment that the patient live in or the population live in not to get the disease.
Thank you so much. It's a really interesting discussion, but we are running out of time, so we need to conclude. I think there is a break, or we will go directly for no break. So we'll go to our third session. Thank you for our speakers, Dr. Misbah, Dr. Azaz, and Prof. Salah.
Okay, thank you, Dr. Wael, and thank you to our distinguished speakers for this session. Now we will go to the recognition part. on our final session titled Innovation and Insights in Type 1 Diabetes Management. This session will be led by the moderator, Dr. Mohammed Al-Nahdal, Medical Director and Diabetic Technology Section Head at the Obesity, Endocrinology and Metabolism Centers at King Fahad Medical City. He is also an Associate Professor of Internal Medicine and Endocrinology at University of British Columbia. Dr. Mohammed, the floor is yours.
Good afternoon, everyone. Thank you very much for the organizer for inviting me to chair this session, particularly Dr. Met'ab Al-Ataibi. It is a great honor and pleasure to meet with all of you, friends and colleagues, to discuss very important topic, which are the innovation and insights in type 1 diabetes management. We have very good speakers today. We will start with one of the well-known figures in diabetes in the kingdom, Dr. Abdullah Al-Gwayhis. Dr. Abdullah Al-Gwayhis is an associate professor at the university, at King Saud University, at the endocrinology section. He's also a part-timer endocrinologist in Dalla Hospital. He's very well known in the field of diabetes in the kingdom and actually internationally as well, particularly the field of diabetes technology and innovation in type 1 diabetes. He served in many committees in Ministry of Health, Wiqaya, and also Saudi Health Council. And he is going to deliver the first talk today. I'm just looking at the title. Dr. Abdullah Al-Gwayhis will talk today about the burden of type 1 diabetes and future direction in the kingdom. Please welcome me to, join me to welcome Dr. Abdullah.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Thank you, Mr. Chairman, for this kind introduction. And I would like to thank the organizing committee for inviting me to give this talk. I think today I have a huge task in delivering a talk that is close and dear to my heart, but 20 minutes is hard. So I'm gonna fly, I'm gonna select what I say about each slide to meet the time limit. These are my disclosures. I will try to cover these sections about type 1 diabetes. I have to say initially that when we look at the burden of diabetes or epidemiology of diabetes, there are some data, local data in Saudi Arabia, but they are mostly type 2. We do not have a lot of insight or published reliable data about type 1. There are few, but not as much or not even close to what we have about type 2 diabetes. So I will touch on what local data available, but also a significant part of this talk is on a global data. So we can see that this data is about 2 years or 3 years ago, and published, and it shows Saudi Arabia among the top 10 countries. This is not the top list or the top list of 10 countries that we want to be in, but the fact is we have problem with type 2 or type 1 diabetes. The incidence is high in Saudi Arabia. And if you look at the left side of the screen or on your right side, if we look at the incidence, we are among the top 10 countries. And surprisingly, there are 3 Gulf states, Kuwait, Qatar, and Saudi Arabia. Whether there is a genetic background connection or historical genetic connection between these countries, that might be one of the explanation. But the fact is we have rising incidence of type 1. Type 1 is fundamentally different than type 2. They have a common and share suffix, diabetes, but they're fundamentally different. So often we do combine or mistake type 2 when we talk about type 1, that we include type 2 in it, but it's totally different. And we have to make this distinction very clear, because what we provide as a healthcare sector for those patients has to be different based on their pathophysiology. Why we do have this rising incidence? 10, 20 years ago, Saudi Arabia was not on the list. Something is changing, demographics. Incidence of type 1 in general is increasing globally. Looking at the global data, approximately there are 9 million cases of type 1 diabetes. Children or less than 20 years old are about 2 million. This is, the absolute number is not even close or comparable to type 2. I understand that. But again, this disease is different, and the impact this disease does on the family level, on the social level, and on the health sector level is huge. So do not be taken away by the numbers as an absolute number, though they don't come in close comparison to type 2, but it's a problem. So let's go to Saudi perspective. What we know so far, or what is published, is that we have around 250,000 patients with type 1 diabetes. Personally, I do think this is a huge underestimate of type 1 diabetes count in Saudi Arabia. But this is what's available, and this is what we have to take. About 50,000 are under age of 20. If we go to the incidence rate, so historically we know, as you saw in the first slide, it's around 32 per 100,000 patient. However, this is one of the studies that shows a modeled incidence. So the modeled incidence is something to predict what is happening. This was published a year ago, and the modeled incidence for 2025 comes with a bad news. We have a higher incidence in those less than 15 years of age, which is a common age where the peak incidence of the diagnosis of type 1 occurs. So this puts that as 58. So what does it mean? It means that even we are becoming close to the Scandinavian countries, something we don't have anything in common to share with. Not climate, not genetic background, not cultural behavior, etc. But there is changes occurring globally. There is changes definitely occurring locally that lead to this incidence, and we need a lot of insight and research to understand the impact of these changes. Unfortunately, it does not come alone. Diabetes put a patient at risk to problems, to complications. So 1 in 4 approximately of early childhood diagnosed diabetes, type 1, when I say diabetes, I mean type 1, will have retinopathy, 1 in 5 approximately nephropathy, 1/3 will have some symptoms or neuropathy. Why this is important? Well, diabetes by itself, it causes a lot on patient and on healthcare sector. And since we are talking about burden of diabetes, the more complication you have, the higher the bill. So whether the patient will pay or the health sector will pay, it's a huge burden. So one after another, this is an added burden on the healthcare system. And it's not only complication, also there are associated disease. Autoimmune comorbidity is very common, diabetes or type 1 diabetes and autoimmune disease. And Other autoimmune disease do occur more frequently in this population with type 1 diabetes. Approximately, and this is again global data, this is not local data, 1 in 5 individuals with type 1 diabetes will have at least one autoimmune condition. Most common autoimmune condition, where is it? Yeah, is autoimmune thyroid disease. Second, celiac. Second, autoimmune gastritis. Again, this adds to the burden. If you guys think about celiac disease, let alone thyroid, celiac disease, and when I remember vividly about 10 years ago, it's really hard on the patient because they need a gluten-free diet. Now, who provide the gluten-free diet? Patient used to struggle. Not they are not struggling now, but it's much more better now. 10 years ago, I do remember there's only one place in King Abdulaziz Road that will provide a gluten-free product, and it's expensive. The government has a program to support those patients, but still, they struggle in a city like Riyadh. So imagine in a different city, whether Dawadmi or Ghariyat or any smaller city than Riyadh, the struggle is even higher. So when you think about this, you get more perspective if you see those patients or have a closer relation to those patients, because then you can put your hand on the pulse or feel the burden, not only of diabetes, also what comes with diabetes. Let's shift to problems comes with diabetes, mortality. Do they have excess mortality? Well, we were taught historically in medical school, younger patients are at lower risk of cardiovascular disease, mortality, etc., and this is true. And we were told that diabetes, the characteristic of diabetes is low weight or being underweight. And that was true, but not anymore. Diabetes by itself carries a lot of risk factors. So if we look at the mortality from this large cohort in Wales, and it has a respectful numbers, 3,000 patients, followed for a mean of 11 years. So we accumulated 42,000 patient year of data. It's a cross-sectional study that looked at the risk factor for cardiovascular disease based on the European Cardiology and the European Study of Diabetes Association guidelines and the way they characterize risk factor for diabetes. So the key finding that death rate is high in patients with childhood diabetes. That is 3 times more likely than the general population. And when we say childhood, we mean that diagnosis of type 1 diabetes early in life. And we will see that earlier, the diagnosis of type 1 diabetes, higher risk in the future. Age distribution of death, the highest mortality occurred in the age group 15 to 30 years old, and we will see why. Okay, so if we look at the mortality rate from the same study based on age category, so we have in the black bars patients or observed death in the patient with type 1 diabetes. In the blue or dark blue bars are expected death in age-matched population without diabetes. And in any age section and any age category, you can see the excess mortality rate in patients with diabetes. In particular, in the age group 15 to 20 and general 15 to 30 years old. So why is that? And what is driving this problem? Well, many causes. Among them, they are not the only causes, but those the identified causes, diabetes, ketoacidosis. It's a huge problem. Yes, it's less now. However, it's still a problem. Those involved in ER and internal medicine, it's a frequent weekly problem they observe and see in their department. Hypoglycemia, very hard to ascertain, but the phenomenon of dead in bed is something real and scary. Suicide, whether due to psychological burden or other reasons, is also associated with type 1 diabetes. Now, other causes like complication, etc., also contribute. So let's shift gear to the cardiovascular risk. And again, and this is what I mentioned earlier, patients with type 1 are not thought about to have high cardiovascular risk. We only think, or we used to think, or we are programmed to think, or we taught to think in metabolic syndrome. Patients with fat, bedridden, etc. So type 2, elderly, middle age to late age. Well, however, this is all true, but we overskip or overlook the risk factor associated with type 1 diabetes. So this is again a large cohort, around 40,000 patients, and they have, so this cohort all type 1, mostly females, age group what you expect from type 1, and disease duration mostly less than 10 years. Okay, so only about 10% have duration more than 10 years. And the alarming finding that more than half, approximately 54 patients in that cohort scored high cardiovascular risk category. So they have the 10 years cardiovascular risk mortality exceeding 10%. So in medical terms, those at higher risk to develop cardiovascular disease. The problem with cardiovascular disease on top of diabetes, the burden is even tripled or more. So common comorbidity in those patients, hypertension is the commonest, which is also prevalent here in Saudi Arabia. If we look at the age category in this cohort, those who are less than 35 years old at the top of the screen, 33% of that category had high cardiovascular risk, even at this young age. And then the second age category, 59 or 2/3, had high cardiovascular risk. The third category is more than 65 years old. 70% of them were at high cardiovascular risk. That is significant. And if you see the shift from the lower age category to the higher age category, it's huge. We are like doubling the percentage. So something is happening between being less than 36 years old and more than 65 years old. And diabetes, type 1 diabetes, is elevating that risk. And there is something that we need to do as a healthcare system to address this increase in risk to reduce it. We might, and probably we can't eliminate it, but the need to reduce it, to reduce the burden, is really something very important. So what is driving this risk? Smoking. So dramatically escalate cardiovascular risk in individuals with type 1 diabetes. Now, smoking, if you ask any patient, no, I don't smoke. He thinks smoking is only cigarettes. Well, the bad news, no, it's not only cigarette. Cigarettes, what they call it, vape, hookah, shisha, any inhalation apart from the normal oxygen or the normal ambient air is smoking, should be smoking. And all kind of smoking, whatever the device is, carries its own risk. So in this cohort, the smokers, 77% among the smokers had high cardiovascular risk. Among the non-smoker type 1, only 47% had high risk. So smoking plays a huge role. Now, smoking is common in many countries. Some countries have declining rates. Some country has rising rate. Unfortunately, in my personal opinion, I think we are on the rise. There is no street now in Riyadh that you cannot find an outlet or a shop to sell smoking in a very nice way. It's new vape flavors. They promote it as safer smoking, which is not. So this is a real public health problem that will affect us for generations. So if you are a smoker, your relative risk for cardiovascular problem doubles. So this should be in mind. But it's not only cardiovascular risk. Among smokers, the atherosclerotic disease was more prevalent. Among smokers in this cohort with type 1, albuminuria was significantly higher. Albuminuria is well-known risk factor for cardiovascular disease, also impaired renal function. So smoking is a really dangerous risk factor. It has a lot of problems, but in patients with type 1 diabetes, it accelerates and amplifies the bad effect. What else? BMI. So in this cohort, rising BMI, the higher BMI, the higher the score. And this makes sense, but we don't think about BMI, weight, obesity with type 1 the way we think about obesity in general population. We perceive or we think, and I was taught in medical school, that was true years ago, but it's not true anymore. Obesity, overweight is a problem in type 1 diabetes. Duration of disease. The longer you have type 1 diabetes, probably the higher the risk. And here it was significant. The cutoff was 10 years. To prove the point that BMI and obesity is real, this is a couple or multiple studies from different countries. And you can see that the rate of overweight range from 15 to 39 across different countries and studies. The range of obesity range from 2.8 up to 17.2. So it's a real problem. Locally, this is a study I published earlier this year. Across the country, there's 1,000 patients in this study, and see obesity. 13% of those patients, all type 1, are obese. 25 are overweight. So it is a real problem. So we should not underestimate the weight management in type 1 diabetes. Mortality, 3 minutes, okay. Mortality is also an issue with type 1 diabetes. And this slide, just to give you a perspective, so if you look, this is the matched control, patients without diabetes. This is patients with diabetes. And this is at the age at diagnosis. If you're diagnosed in the first 10 years, the expected life lost to diabetes is 17 years old. And this gap closes if you are diagnosed later in life. So the earlier the diagnosis, the higher the risk. This, not to scare us, this to open our eyes that we need to act and find solutions to care of those patients to lower this risk. So I will skip that, and this is the last that I will present due to time. So the other burden of disease, which is kidney-related disease or diabetes-related chronic kidney disease. I don't have a local data about type 1, but this is a global perspective data that look at type 1 related kidney disease, and they report the DALY, which is the disability adjusted life years. This is a popular metric, health metric used by public health authority to understand the effect and the burden that this disease put on our healthcare system. It combined two metrics. Years of life lost due to premature mortality, and we assume it's before 65, and years lived with disability, where you cannot participate in the production into the country you're living in. So it gives you a flavor or an idea how strong the disease exerts a lot of pressure on the health system. So if you look at the prevalence, we're talking type 1 related kidney disease. Globally, around 50,000 patients. Do not underestimate the number. Absolute number are small, but the effect is huge. And this is an increase of approximately 90% since the 1990. Mortality also, 64% increase since the 1990. If you look at DALY, approximately 4,000 DALY, and that's a lot. That costs a lot of money and pressure on the system. I don't have specific data, but from this article, the death rate in Saudi due to diabetes, type 1 diabetes related kidney disease, 2.8 estimated, and the DALY are 145. Huge number, because we are largely young population, and the DALY is depends on the age where you are most productive, and this is a huge problem. Risk factors, all prevalent in Saudi Arabia: glycemic challenges, hypertension, obesity, We have problem in delayed screening, how many patients I can see without proper renal screening, albumin creatinine ratio due to different reasons. So my last slide, remember the complete picture, integrated care is really important. We have problem with microvascular disease in this population. We have problem with cardiovascular disease and mortality. They have multiple comorbidity. Among them is obesity, which we should not forget. Autoimmune disease is associated disease and should be part of the usual care of patients with diabetes. I really would like to keep going on and present some financial data and economic burden, but if I keep going on and on, the organizer will really get upset. I hope I was able to shed some light on the burden and the difficulties of managing patients with type 1 diabetes. I give you some light and idea how type 1 diabetes can affect the health system in the larger scale. Thank you very much.
Thank you very much, Dr. Abdullah, for this inspiring and comprehensive presentation. Please hang on, do not go away, Dr. Abdullah. We will have a question after we finish the session. Next speaker is a very well-known figure and international figure in the field of type 1 diabetes, Dr. Emanuele Bassi. Dr. Bassi is a professor of internal medicine, head of diabetes at San Raffaele Vita Salute University Hospital in Milan, Italy. Dr. Bassi is a physician scientist, professor of internal medicine at San Raffaele Vita Salute University. He is currently the head of the private medicine department and the diabetes hepatology unit at San Raffaele Hospital in Milan. Professor Bassi has coordinated several clinical research groups. He is a member of several scientific societies and has been on the editorial boards for several journals. Thanks to Professor Bassi, now screening for type 1 diabetes and celiac disease is approved by the Italian government just last year or beginning of this year. Professor Bassi was in ISPAD in Montreal. I saw him there, and we have met also in Colorado just a couple of days ago in preceptorship for type 1 diabetes screening. So he's traveling all over the world. So there is no wonder that he is not able to come today, but he is joining us online. And he is going to talk about the Italian experience in approving type 1 diabetes and celiac disease screening. And hopefully we can learn from that experience and come to approve a national screening program for type 1 diabetes. Dr. or Professor Bassi, the podium is yours. Thank you very much. Or the mic, maybe now is yours. Professor Bassi, I think we have a problem with the voice. Can you, some of the organizers, please help us? It's still not clear, unfortunately. Can you try, Professor Bassi? No, not clear yet. Wait. Just bear with us. There's technology problems. We're sorry. Can you, just exit Zoom? Is it Zoom or and sign in again, Professor Basi? Yeah, just get out and get in again. So that might help.
Can you hear me now? Can you hear me now? Hello?
You try now, Professor Basi?
Can you hear me now?
Yes, yeah, that's good. You can go ahead.
Finally. Do you see my presentation?
No, we see you, but we don't see the presentation. Can you maybe share the presentation if you did
Yes,
not? Yeah, okay, now we see it. Okay, good. You can go ahead.
I'm sharing the presentation. Okay. So thank you very much for the invitation. Sorry about these technical problems. I'm honored to be invited and speak about the Italian law, Italian experience on screening for type 1 diabetes and celiac disease. Have been asked, and I'm very happy also to provide the background about and the rationale of screening. Now we know that natural history of type 1 diabetes is characterized by a genetic background and then by a still unknown trigger from the environment inducing autoimmunity, which is lately responsible for the progressive metabolic dysfunction and at the end, clinical onset of the disease. We are happy that we have some very good markers of autoimmunity, which are circulating autoantibodies that we can exploit for identifying people who are at risk for the future development of type 1 diabetes. And islet autoantibodies have been characterized, and now they are easily measurable in peripheral blood, and they include 4 specificities: anti-GAD, anti-IA2, anti-insulin, and anti-zinc T8. And by screening people who are non-diabetic by these antibodies, to make a very long story short, we now know, and what you are seeing in the screen is just an example from the family study conducted at San Raffaele in Italy. If people have no autoantibodies, they have basically no risk of progression. While if they have 2 or more out of the 4 autoantibodies, the risk is very high, and this risk in children is reaching 100% of probability of progression. So this means that the screening is very useful to identify in advance people at risk for type 1 diabetes. Over the few last decades, a number of family studies, such as the one I showed you, progressively consolidated the concept that screening by antibodies is able to predict future type 1 diabetes. However, most of the people developing type 1 diabetes have no family history. So if we want to identify future cases of disease, we have to do the screening not only within families already having some members affected by type 1 diabetes, but move to the general population. And indeed, the natural history of type 1 diabetes is exactly the same, whether or not there is a family history. The islet autoantibodies can be used as a tool to screen the general population to identify future cases. However, why should anybody, especially children and adolescents, why should they undergo a screening? Well, there are a number of reasons which are here listed. The first reason is to reduce the incidence of DKA. DKA stands for diabetic ketoacidosis, which is affecting a large proportion of especially children developing type 1 diabetes at the time of clinical onset. And this is a severe complications, very stressful, and still associated to a residual mortality. And it is demonstrated, and again here I'm quoting the family history conducted at San Raffaele, in people who already have been identified as at risk for type 1 diabetes because they are positive for autoantibodies. Since we know that they are at risk, they can be educated about the disease, they can be followed up, and they can be treated promptly with insulin when this is necessary without waiting for the progression of to diabetic ketoacidosis. And a number of other advantages are associated with the screening of people identified in their pre-symptomatic phase. There is an improvement in short-term outcome. There is the reduction of the psychological stress of the appearance of type 1 diabetes, which is always a devastating experience for families. In addition, knowing that somebody is predisposed to type 1 diabetes provides the opportunity to have access to participate in clinical trials, or even to have access to the only therapy now approved or available to try to not to prevent, because this would be too much optimistic, but at least to delay the progression to clinical disease. And this drug is a monoclonal antibody called teplizumab, and it has been demonstrated in a very important clinical trial conducted by the network Diabetes TrialNet, that people, children and adolescents, randomized to receive teplizumab showed between 2 and 3 and more years of delay in the clinical onset of type 1 diabetes. All this provided the basis to promote screening in the general population, and in Italy we were lucky enough to convince the parliament to pass a law which incorporated the program of type 1 diabetes and celiac disease screening in a law. And the general objective was and is to screen and make available screening to all children and adolescents in Italy in order to identify people at risk for type 1 diabetes, but also by associating the screening for celiac disease to identify the many people having celiac disease undiagnosed. We heard from the previous lecture that celiac disease is associated to type 1 diabetes in a number of patients, and the two diseases have a common share, some background, some genetic background. So celiac screening is in a way boosting the screening for type 1 diabetes. And specific aims of this law were, of course, prevention of diabetic ketoacidosis for the reasons I just explained, and identification of people who can benefit from some intervention before the clinical onset. And on the celiac side, since there are many people with celiac disease but undiagnosed, they can be identified, and a prompt therapy consisting in gluten-free diet can start, just preventing all the associated complications. As soon as the law was passed, in Italy, the ministry asked us to conduct a pilot study in order to test organization, feasibility, and acceptability of such a great commitment, such as the screening in general population. And this pilot study was planned in order to make this test, and the design had 3 pillars. The family pediatrician network, which is existent in Italy, the capillary blood sampling as the tool to do the screening, and the centralized lab to make the assay. Of particular importance is the network of family pediatricians, which is existent in Italy, because if we want to go and screen all children and adolescents, we need a network in the field. And in Italy, we have this fantastic network of pediatricians who were responsible to contact participants and family, presentation of the project, administration of the informed consent, do practically the capillary blood drawing, collect blood, and ship everything to the central lab. And this pilot study was completed, and it was a success. There were 3 privileged ages to do the screening, which were around the age between 2 and 3 years, between 6 and 7 years, and between 10 and 11 years. These 3 ages were chosen because they are corresponding to the peaks of seroconversion for type 1 diabetes. And in the table, you may see specific numbers which show that the trial was successful. Capillary blood was taken by finger prick and collected in microtubes for autoantibody measurement and in cards
for HLA typing. DBS is the acronym of these Guthrie cards, and this was useful to make HLA typing, which is important to define the genetics of celiac disease. Here just the great summary of the screening, and people having 2 or more autoantibodies and therefore being at a very high risk to develop a future type 1 diabetes were 0.2%, which is not different from what found in other countries, while the prevalence of celiac disease autoantibodies, transglutaminase, was much higher than expected. We found 2.8%. Going in more specific aspects, you may see that in the 3 classes of ages, the prevalence of type 1 diabetes specific autoantibodies was more or less the same, 0.15, 0.3, 0.1, and these are the various combinations according to the different assays used to measure autoantibodies. While in celiac, we found 2 aspects. First, a much higher prevalence of transglutaminase antibodies. You see that around the age of 2 years, 4.1% of children were positive for celiac antibodies. However, for unknown reasons, at the age of 6 and at the age of 10, this prevalence was reduced. And of course, this is a matter that we have to study and understand. So, by concluding, the topic is population screening for the early identification of type 1 diabetes in its pre-symptomatic stage. So the first question is it worth? Yes, it is. Again, we heard from the previous lecture that type 1 diabetes is largely prevalent and also is characterized by an incidence which is continuously growing, and we don't know why. So how can we do the screening? This is quite simple, by islet autoantibodies. Is the screening per se beneficial? And the answer is yes, especially because by identifying people in their pre-symptomatic phase, this can result in a drastic reduction in the incidence of diabetic ketoacidosis, which is very, very good. The answer, is it feasible? Well, there are many programs around the world. Many are very important and famous. For instance, FRIDA in Germany or ASK in Colorado, but there are other examples in Sweden, Denmark, in Finland, and in UK. And in Italy, we were very lucky to be able to have a nationwide screening program by law. This is the first example in the world in which a screening for type 1 diabetes and in addition also celiac disease was made available to all the pediatric population by law. We were the first example, and indeed there are many, many other countries which like it very much. And the test of the pilot study was very successful and showed that in terms of organization, feasibility, and acceptability, this large screening can be done in practical terms. And I wish to thank you once more for the invitation and for listening. Of course, here are the many people who collaborated with the pilot study. Thank you again.
Thank you very much, Professor Bassi. Just
hang on. We will have the last presentation, then we will have a session for question and answers. The last presentation will be by Dr. Abdulaziz Al-Qannas. Dr. Abdulaziz Al-Qannas is a podiatrist surgeon specialized in diabetic foot surgery. And he is the first one, I think, who has been accredited from the Saudi Health Council as a podiatric surgeon specialized in diabetic foot surgery. He is well known in the field of diabetic foot, and his efforts has been very valuable in preventing amputation for many patients all over the kingdom. He is going to talk today about diabetic foot in the Kingdom of Saudi Arabia. Dr. Abdulaziz, the podium is yours.
Assalamu alaikum. The last lecture I did in Saudi Arabia was at 2009. I was away for a long time. I really appreciated for the invitation for the organize of this distinguished. You know, a couple of years ago, I want to mention a couple things. A couple of years ago, I think 20 years ago, I received invitation from Ministry of Health to establish diabetic center in Saudi Arabia. That time, the infrastructure is booming to building center, building hospitals. When I joined that group, they show us a picture of the center, which is now you see at King Salman Hospital, in Al Qasim, and everywhere. I asked them, I said, this is not enough for our population. They asked me, what do you recommend? I show them complete program and guideline from Joslin Diabetic Center in Harvard, because I did my residency at Beit Israel Dignus Hospital, which is in Harvard Medical School. Then after 3 or 4 times meeting, they kicked me out from the committee. I accepted. After 12 years, I received a call from Deputy of Minister of Health, asked me to come. He show me my concern about the diabetic, and he said, you were right that time. We are sorry, Dr. Gannas. I said, you know, I'm ahead of the diabetic in Saudi Arabia because I saw it in America, and I want the best thing for my country. 3 months ago, I received a call from Deputy Minister of Health, asked me, because he told me there is a big issue in diabetic foot in Saudi Arabia. I told him, are you going to kick me again? He said, no. I said, okay, we have to be fair. I showed him what's the best for diabetic foot. But the saddest part now, I see everything diabetic foot excellency, diabetic foot center, but there is A, which is diabetic center. It's been forgotten now. But I am diabetic foot surgeon, but I saw the Joslin Institute at that time. Then, if I tell you 2 things, you will be shocked. First, diabetic foot unit established by endocrinologist, Dr. Orbian, which is really, we are proud what he did. Then we follow his step. The second thing, the best diabetic foot surgeon in Europe is endocrinologist. After he finished his endocrinologist residency, he went to Harvard and he did residency with my boss, Dr. Guerini, because he's Italian and he's Italian, and he let him get in the program. But what we did in National Guard, when we established the unit in 2000, mostly of our patient, it's ER. That's what now missing. When I have a meeting with Ministry of Health, I told them this is the biggest issue. There is lack of surgical approach. There is lack of misdiagnosis of the case. I will show you many cases it's being done in Saudi Arabia, and due to lack of surgical approach. And then they asked me, what you like to recommend? And I said, you have to establish diabetic foot fellowship to teach people how they do the surgery. I will show you. You know, when I go to lecture in Europe or US, always I show them this. They always ask me about my camel, and I tell them it's in the parking. You see, this is a video. It's in 1901. It's almost 125 years ago. For amputation, I took it from one of my colleagues. Can you, excuse me, can you turn it on, please? Okay. This video, it is in a library in Berlin, and they smuggle it, and I took a copy of it, and I will show you. Okay, what we did in National Guard, we established a guideline, but everyone try to avoid the guideline. The diabetic foot, what we did in ER, if there is ischemic limb, is go to our colleague in vascular. If there is Charcot foot, go to our colleague in orthopedic. If it's not solvable, it's go to general surgery. If it's osteomyelitis, septic, and there is good blood circulation, admit under my name. But here is the issue. The issue, when we call vascular in the ER, we ask them, there is a ischemic patient. They said, how is you dictate the pulse? I said, we use the Doppler. He said, no, I want CT runoff. You cannot do CT runoff for patient with renal impairment. Then the patient stayed 2 days in ER. Then we call orthopedic if there is Charcot. He said, yeah, but there is no ulcer. I cannot take it. What we did, I took all the cases under my umbrella. I admit every case is ischemic, Charcot, and septic. What we did, we went to intervention. Our colleague, we asked them, can you help us? He said, yes, but you have to help us. I said, how? He said, you admit some patient which is not diabetic under your name because they don't have privilege to admit in our hospital. We will help you, help us. And we did. There are 3 consultants. Now they are 45 in National Guard. This is the patient when come to ER, diabetic. No one wants to see it. In government hospital, I'm talking about. No vascular. Some of my colleague, pediatric surgeon, doesn't want it. And no orthopedic, no plastic, no general surgery. But the funny thing is, when the patient come to private hospital, everyone wants it. And there is no guideline. Who is run first will take the patient. This is the cases what we see in our hospital. This is an ER. You see, this is a blister. It's easy cases. What they do, government hospital and some private hospital, I see cases like, if there is a blister like this, it should be just use a small needle, puncture it, and give him oral antibiotic, discharge him. What they do, they take epidermis and the derms, and they take subcutaneous fascia, and they send the patient to us. We try to educate him, but we are a limited number. Now, we found out the biggest issue is not follow the patient. No, we found out one of the biggest issue we have, surgical approach and lack of surgical skills and misdiagnosis. Here is another case. The same case, let's go back, same case. Here, this patient end below-knee amputation. Because what they did, they took all the derms and epiderm, the subcutaneous fascia, and they took the neurovascular bundle. And the patient end below-knee amputation. Here is another case. This is cellulitis. Just give him antibiotic and go home. No, that's what they do. They debride it, then they take in their way the neurovascular bundle, then they end with 4-foot ischemic, then he will end TMA. It's the same patient. Look, here is blister. They just take it to the OR and take everything. I asked one of my colleagues, he is a pediatric surgeon, he went to small city, and I asked him, what do you like to do? He said, I wish I hold the blade from the surgeon, not just cutting. Here's another case, same case. This also, here's cellulitis and a blister. Look, they open it all the way to above the ankle, and they expose the tendon and the fascia, and it takes long time to heal. That's why there is a big number in diabetic center, especially in diabetic foot clinic. Just follow up for dressing. It takes 3-4 months to complete heal. And this is the type of amputation I saw coming from different hospitals. There is no way you can do this amputation in any hospital overseas. This is supposed to be amputation like this. If you compare it, this is, no one accepted. Why we accepted here? Because we asked them, why you do these cases like this? They told me, because Dr. Gannas, nobody trained us. But the problem, every hospital now just take the patient OR, debride, take the dorsalis pedis artery in the way, posterior tibia artery in the way, then they end below-knee amputation. That's why we have high number amputation. They always blame the patient not follow up. No, the surgical approach, it should be changed in this country. That's why they avoided me to come speak in the conference about the diabetic foot. All my colleagues, because I show them, they're like 1 month, alhamdulillah, he complete close. Here is another case. You see, simple case, even a polyclinic do it. What they do, this is a blister. It should be just a stab incision and send the patient home with oral antibiotic. No, they are excising all the derms, epiderms, and the fascia, expose the tendon, and it takes 3-4 months to heal. This is another case. This is also the dorsal aspect of forefoot and midfoot and hindfoot. You see here, they just take the whole tissue. And we take long time to help this patient. And I show you what we did. We took him to the OR, we debride, and here we debride again, and we did skin graft for him. Here is another case, also from other hospital. I didn't mention which hospital. Every hospital do this. Every hospital. We don't know why. Nobody can answer us. And believe me, I showed the Ministry of Health, the deputy, those cases. And what they did workshop last month, and 45 attend the meeting. And no one attend from ER. No vascular attend, no orthopedic. And I was upset. It should be those guys participate. Then I received a call from Saudi Health Council, asked me to create a program. I said, I'm no longer in the hospital. I love the hospital. Then they try to contact different hospitals. No one interested to do any fellowship program for diabetic foot. But the saddest part, if those patients come to private sector, everyone want to grab a piece of this cake. This patient came from, I think, north of the region or south. If you see here, sorry, go back. If you see here, the bone exposed, this is the calcaneus, this is the talus, and there is a collection in the leg. We took the patient to the OR, and we open it lateral and medial, and we pack it. But the old school here, they open it and leave it for 3-4 months, then end below or above amputation. And the last one, can you give me extra time? This is we took the patient to the OR, we remove and excise all the osteomyelitis. Sometimes. Here is one case, came from another hospital. You see, what they did, they opened medially, exposed it, lift it, and they told them, you're going to be above knee amputation. We took the patient in OR, with debridement, we close it, and here is the patient after. Here is another case. He has, this patient, female, she has gas gangrene. What they did, they opened it and they lift it like this for 4 months. Then they told the patient, you will end above knee amputation. We took the patient to the OR. We excised the tibia, and we did secondary closure. Here is the case. In this case, really, it's help between vascular and us, and did by my colleague, Jazwa. This patient has ischemic diabetic foot. We sent the patient for intervention and came back with good pulse. And believe it or not, my colleague, she did it in the clinic, not in OR. She debrided, then we apply special skin graft called epigraft from Sweden, and complete heal. And did by Jazwa, not me. This is a case, one of the best case with multidisciplinary team. And this is another case from another hospital, taken to the OR. Before we OR, we send the patient to vascular and did revascularization. And here is the, we took the patient to the OR, we did revision. 60% from my patient revision in National Guard, and 80% from my patient through the ER. This is after we complete the ride. And this patient came from private hospital. They use IV cannula for her. Look the way we did our surgical approach. We didn't take the whole anterior aspect or dorsalis aspect of the foot and ankle. We took the patient to the OR. You see here is the pus and collection. Then we clean it and we keep the neurovascular bundle intact. Then we did secondary closure. Then we closed it. It's complete heal. And this is also another surgical approach for us. This is also collection. We open laterally.
خلاص بسم الله.
Then see, we close it, but we pack it. If there is any fluid left, then this is after surgery. It took like 1 month. I'm talking also about one part we call misdiagnosis. This is a shortcut, very common in Saudi Arabia. Every time the patient go to the ER, they think is osteomyelitis or cellulitis or infection. What they do, they take the patient to the OR. You're not supposed to take the patient OR. It's already the patient WBC normal, CPR. The only things you have to do, just immobilize this patient. Don't take him over. Here is another case. This patient, no need to go to OR. They took him OR, they opened every part of the foot because they think it's a cellulitis or infection. But it was shark foot. Here's the debridement. This is debridement from a different hospital. This is another misdiagnosis, shark. They treat it as a trauma. And this is after surgery, it's losing screw. We took the patient back to the OR. We did femoral blade, very strong. And this is the revision case. And this is another case. You see, they treat this patient as a trauma, but it's a shark. Then, if you go back here, you see the screw loose, and we have to remove all the screws, and we do another surgery to. Here is after. Last 1 minute. So, there's few cases come to us. It's really sad. They treat them as a diabetic foot ulcer. But there is a rules, a regulation. If the wound more than 2 months not healed, you should do tissue biopsy. This is a patient. It's a melanoma. They treat a diabetic foot ulcer. We took him to the OR. We amputated. Here is another case. They treat it as a diabetic foot ulcer, but this is a melanoma. We took him to the OR. We excise it. We send it for tissue biopsy. Alhamdulillah, came. We did also CT to rule out any metastasis. Nothing will allow him. Here is a 1 minute. I'm done. Some asif. This is also another melanoma. They think it's an ulcer. This is the biggest melanoma. I published it in, I think, 15 years ago. This is the biggest melanoma in the foot in history. And one more thing, this is a Madura foot. They think it's a diabetic foot ulcer. And after we did tissue biopsy, it came fungus. We took him to the OR and almost finished. Thank you. Thanks a lot. Thanks a lot.
Please join us.
I really appreciate it.
Question and answers. Thank you very much for the presentation. And we have really a huge problem with the diabetic foot in the kingdom. Dr. Abdullah, please join us. Professor Bossi, are you still there? Is Professor Bossi with us or no? No? Okay. So he's not with us. Okay. So maybe I'll start with Dr. Al-Gannas. Alhamdulillah, we established diabetic foot unit in King Fahd Medical City, and we had the same problem. Like nobody wants to take it out. So we put the protocols, and if there is a vascular problem, vascular surgery should take it. But eventually, we ended up taking all the cases. So we're taking care of all vascular cases, ortho cases, and other diabetic foot cases. And I think probably it should be the way to do it because no other one is really interested. What do you think about that?
Bismillah. طبعا, I mentioned your unit with the meeting of the Deputy of Minister of Health. They asked me what the solution for the diabetic foot in the hospital. I said, you have an image in King Fahd Medical City. They established exclude unit just for diabetic foot, which is really good. But when transfer later on to Al-Qabida, it's going to be issue. Who's going to take the foot from the group you establish for diabetic foot? Who's going to take the patient? In Mayo Clinic, they have same issue. What they did, they train hospitalists, intern, to go first to the ER, to evaluate the patient, then transfer the patient to the right person, to vascular, to ortho, to GS, to pediatric surgery. But they same unit you have, but they will have issue due to, private sectors. This is belong to me, this is belong to me. But when you have hospitals or interns, go to first, train good. They train them 2 years in Mayo Clinic to figure out which division take this patient. But you really go ahead beyond any hospital, you establish this unit, which is really good. Before they fight in ER, now no longer, because the unit you establish. And I mentioned it to Dr. Abdul Ali. I told them the best unit now at King Fahd. Then I was upset because they didn't fight anyone from it.
Yeah, hopefully we can present our experience, and hopefully everybody will learn from it. But the good thing now, no more fight about patient. And I think the good thing that we have done is now patient is receiving care. Previously, when the patient comes to ER, nobody wants to take their patient, the patient, and or they will take the patient, but they will offer amputation right away because they want to scare the patient to just get away. Or if they do amputation, and then they send the patient. They don't want to spend time because, as probably you know, those patients are very demanding, very sick. They spend a lot of time in the hospital. They may require several surgeries. And nobody wants to commit for that. So hopefully with these units, we can help with the problem. I will open the floor for questions to Dr. Al-Gannas and Dr. Al-Gwehas. Dr. Abdullah, I thought we have a pandemic of type 2 diabetes in the kingdom. But we realize now, not only that, we have a pandemic of type 1 diabetes. And as you mentioned, the last IDF Atlas showed the kingdom number 9 in the prevalence of type 1 diabetes all over the world. Particularly, we're not a big population. We are 35 million, but we rank number 9 all over the world in the incidence and prevalence of type 1 diabetes. Why do you think that happens? What is the reason for that?
Yes, thank you, Dr. Mohammed. So it's true, yes, we have a problem with type 2, definitely. This is a given. But we need not to overlook the coming problem with type 1 because the needs for this population is different. It's not similar to the needs for type 2 diabetes. So sometimes healthcare policy makers or decision maker think, okay, it's all diabetes. They will need or they will be treated the same. And the answer is no. The burden is different. The disease duration is different. The age group is different. Now, the important question why we are seeing a rise in the incidence of type 1 diabetes, and we don't know. It might be genetic risk factors. It might be environmental causes, and definitely both have a role in this rise of incidence. The exact reason, it's still up for discovery, but probably it's a combination of multiple factors, whether it's environmental or genetic predisposition.
Some people blame the food. What do you think?
Environmental.
Like
well, it's
engineered food and other things. And
cow milk versus breast milk. I mean, vitamin D has been blamed for it. Infection, viruses, they might have a role. There's nothing confirmed scientifically. So I cannot say pinpoint a one cause, but yes, we can say it's a basket of reasons and probably interrelated and working together. Why it's in our area, not in a different area? This is also another question. We still don't know the exact answer. Why? Why we have high incidence? We don't have anything in common with the Scandinavian countries, but we do have high incidence.
And unfortunately, Professor Bossi is not here to answer the question, but I will ask you instead of Professor Bossi. He showed in his presentation very good reason to screen for type 1 diabetes, including the incidence of DKA is much less when screening. For example, the ASK program in Colorado, they reduced the incidence of DKA from 30 to 50% to only 5% when they screen for type 1 diabetes. Also, the other screening program showed the same thing, like the FRIDA from Germany, the TrialNet, and the TEDI program all showed the same thing. There was also some evidence to show if there is if you screen, then the blood sugar control is better, the C-peptide positivity, you maintain it for longer, and there also that may be associated with less complication in the future. However, we have no national program now for screening for type 1 diabetes. What do you think we should do now? What is the best next step we can take to initiate a program?
Yeah, thank you, Dr. Mohammed. This is a great question. But we need to think strategically about this. Type 1 diabetes, we think about type 1, this is a lifelong disease and there is no cure for it. However, science is progressing and discovery opened doors. Now we have one window opened, the treatment available to delay the onset of type 1 diabetes is promising. This is the first step. And once you open the door for research and discovery, I think a lot of things will follow. So in 10 years' time, probably I expect it will be much more different in terms of options available. So screening for type 1 diabetes, we saw many programs in Italy and Germany and the US. We don't have a national program here at Saudi Arabia. We have individual efforts at some governmental hospitals. And I hope that one day we do have this program. Is it going to be beneficial? You saw the rate of DKA and the relation between DKA and mortality. One of the reasons that the doctor cited is when you screen patients with risk for type 1, or when you screen the population and the patient and the person knows he is at risk for type 1 diabetes, supposedly that person will receive an education about signs and symptoms of diabetes, healthy lifestyle, etc. So when the symptoms occur, if the patient will not receive a treatment, at least they can suspect or be aware about the onset of diabetes much more earlier than needing to go to the ER with DKA. In this way, we expect to reduce the number of ER visits, the number of DKA episodes. Probably that will affect mortality and morbidity, or part of the mortality and morbidity of type 1 diabetes. This is the hope.
Yeah, I was in Colorado the beginning of this week, and I had the chance to meet with some of the families. They were screened, and I talked to them, and their experience is really great, because some people were concerned that if you screen and they become positive, antibody positive, that might induce some anxiety, and which is true in the beginning. But when I asked them if the time goes back to before you were screened, would you do it again? And they said definitely we would do it. So that just tells you how the early detection of their disease have helped them. Any question from the audience? I guess I asked you a lot of questions, so I want to allow the audience to ask questions. Can we have a mic, please, for Salah?
Thank you very much. I'll stress on the point that what Abdullah has mentioned very clearly. There is a difference between a patient with type 1 diabetes and a patient with type 2 diabetes. Let's just make no mistake about that. The burden of the disease on the patient, the burden of the disease on the society, the burden of the disease on the healthcare system, the burden of the disease on the family itself is far too much different from the type 2. And I think this has to be taken in consideration. And Dr. Abdullah has very clearly put it, is that let us not compare number to number, because compare number to number, it is not comparing apple to apple. It is totally different. This is one. The other thing is that I think the people who are interested in screening, they have to convince whoever is going to take this decision that the expenses of the screening and doing the screening will result in something positive. Not necessarily you can prevent, but probably you talk about the complications, the type of admissions, the burden on the health system and all this. And this is not going to be easy, but again, it is not impossible. And I think somebody has to start this.
Yes.
And I know that Abdullah, by my personal knowledge with him, you see, and his efforts, and I think he's starting something with that, but it cannot be done, this sort of project cannot be done that people will pay themselves, you see. If it becomes qanoon and a screening, we have seen over the years, we have seen many screening programs which were not there, but now they have become mandatory screening programs in neonatal, whatever it is. And I think probably somebody has to start. من يعلق الجرس. And I think somebody has to start with a convincing supporting data about the burden of the disease and how the screening program will minimize the burden of the disease, will improve the life of those unfortunate patients. And I think this has to be started somehow.
Thank you very much, Dr. Salah. The very, very important points. And just to illustrate the difference between type 1 and type 2, if you think about how many health-related decisions that a patient with type 1 diabetes take every day, it depends on what study or resource you're reading, but it's between 80 to more than 300 health-related decisions that the patient should take every day. So just imagine how big is the burden on the patient with who is living with type 1 diabetes. I worked in Canada for 12 years. We used to fill a tax cut for those patients who's living with type 1 diabetes. So it is considered like a disability, and they get tax cut for it because of how much time they spend every day managing their diabetes. So I think it's a big burden on them, and actually many of us do not understand that. For the screening, hopefully with small steps that we take, we can reach our goal for a national screening program. We are leading a study in pediatrics. It's a multi-center trial over the Gulf states to screen people age 18 and below. And we're starting also a clinical program in King Fahd Medical City for adults. And hopefully, once we present our experience, that will convince the decision makers to adopt this screening programs all over the kingdom, because we know it is beneficial for both patients and healthcare system. And it also saves cost, because if you look into the cost of DKA admission, it's huge. So we are going to save a lot when we prevent DKAs, beside other things that screening program will offer. If there is no more questions, probably we can end our session. Thank you very much again. Dr. Abdullah, you have a last thing to get. Go ahead.
I just want to mention one point, Wuqaya, I think through Dr. Azaz, they are planning to have diabetic food screening, and which is really good. In United States, they call it at-risk food. They will do it here, inshallah. This will minimize the amputation by big number. When you're screening the diabetic food, you see if he has peripheral neuropathy or ischemic. And I think they are now leading this in Saudi Arabia, Wuqaya. And I really appreciate it if they really start for this program, because it will help a lot.
Yeah, we're happy to share our experience. We have a program from prevention to all major surgeries in diabetic foot, and we are happy to share it with whoever is interested in that. Thank you very much for the presentation. Thank you much for the audience for coming on Saturday afternoon, and also thank you for Wiqaya and the organizing committee for inviting us, and hopefully we see you again in another event. Thank you very much.
Thank you, Dr. Muhammad, and all the thanks for our distinguished speakers. Now for the final recognitions. Starting with Dr. Muhammad al-Manzar. دكتور عبد الله القويحس. دكتور عبد العزيز القناص. Now we will start with the companies, the event organizer, the company of innovative design. The strategic partner, Smart Health gratitude to the scientific committee for their efforts and to our sponsors for their generous support. Thank you all for being here.